epigenetics expression. So what we can see is that collagen makes a epigenetics change that leads to a cytoskeletal organization and cell proliferation. So those concepts of mechanobiology will lead to a change in biochemical, in cell biochemical, in the cytoskeletal typography, and in the change in the response. That's what we've been doing. So we can find a balance, similar things, but when there is some inflammation, we can see that there is not balance, that the cells aren't stabilized, and there is a change in the matrix, in the cell matrix. Then we can see that there is psoriasis that has a hyperactivity that will lead to a fibrosis of the skin we are working with. So basically this tissue adds a mechanotransduction alteration, so the fiber cannot move anymore. Like if, for example, I have one fiber and I try to move it, but I cover it, it won't have the same activity. So that's what's happening. So that's our relationship with inflammatory interactors. We have an activation of different components, and we would like to have a control of hypothesis, an increase of lutein 10, among others. So this is where we can see mice in mechanotransduction, the change of stimulation to lead to oocyte 1. So this is paracrine, endocrine, juxtacrine, and nerve. And it's important to manage all these within the concept that we are having in order to manage everything at a cell and nerve level. Now this is all about chemotaxis, and the most important part, magnetotaxis. We know that the concept is stimulating one part in order to put tissues, to put stem cells by stimulating mechanotransduction. So we need to work with the extracellular matrix plasticity. So this control is 3 a.m., 3 p.m., and there is a soluble change where there is an increase of temperature, and from 3 p.m. to 3 a.m. to 3 p.m. there is an alkalosis. So when you're getting vitamins, you should do it at 2 p.m. Otherwise, it will break the total control that we are handling. So we need to do everything according to the matrix wants. So we are having the mechanotransduction process at a therapeutic level, but it's important that you remember that we want to induce an anti-inflammatory process. And that's what I can achieve with that equipment. And with that equipment, we also have the modulation of other receivers so that there is not an inflammation, but that we can provide a proper response. The chronic inflammation is an aberrant cell fate. They change the concept. It's not only that I need the mechanotransduction, it's happening, it produces a damage. And they keep changing the process from one matrix to another. When there is an inflammation, there is a process in which cytokines increase and the cycle is damaged, and acute inflammatory happens, persistent inflammation, and there is an exit as compensation, and that's why there is fibrosis, because the matrix is stiffed in all different tissues. And that's what we need to reach, a physiological inflammation, so that mechanotransduction is the proper one, and that we can have a proper control on that chronic inflammation. And that's what it causes, a chronic inflammation. That's 40% of the causes of the chronic disease nowadays. So we need to find that inflammation in cytoleukin 1, cytoleukin 6, in order to increase cytoleukin 10. Okay, I'm going to finish very quickly. We have the interleukin 6, that's the starting point. But this phase of blocking the inflammation that's the worst part of mechanotransduction, and we need to change that. However, TGF-beta, that's the problem in the chronic part, but it modulates this severe and the acute phase. So it's important to know what we're doing in all different phases, because if we have one protocol, we need to know what's happening in all different phases. Of course, we need to talk about the activation of the neurological process, because we are managing pain, and that's how we manage neuroplasticity with the process of nerve management. And that's how we can manage the leukocytes activation, among other things. And that's how we can have everything that we need. And that's how we can bring all these things to a control management. So what should we do? We need to increase those interleukins in order to control inflammation. But it's not me who is creating this, but this. And what we are going to see is that there are many articles that are talking about mechanotransduction for asthma and some allergies, and that's very interesting. We are going beyond. We are working on the immunological system, because we are increasing interleukins 10, decreasing interleukin 2, and there is an stabilization. And it's the same for the TGF. We can have the Claudin 1 doing that same interaction. You can check that in autoimmunity. We have in the COPD, the pulmonary problems when we produce more TGF, and that's the same situation that we are seeing. It's important to remember that the starting process are of 3 weeks, the remodulation is of 2 months, and stabilization is of 18 months. So when patients say, hey, it's only been 3 weeks and I'm doing a little bit better, so that means that you are in the good way. So if you have one chronic patient and next appointment they say there is nothing happening, it might be because of a psychological factor. So remodelization is very important, at least 1 year minimum, the exit of stem cells, so that there is a differentiation and a plasticity of the matrix by increasing the inhibitors and by improving the inflammation of proteins concepts, so that the rigid matrix can become a soft matrix. So that's what we need to manage, homeostasis of the matrix. And please, in all mechanotransductions, we are not using AINES, we are not using corticoids. For example, if I'm using corticoids because I'm having lupus, that's okay. But if we're using corticoids like all of a sudden, there will be a negative effect. Like there won't be any results at all. So that's what we are seeing. We can find and talk about all the processes of diamagnetic so that we can handle all this. Thank you very much.
Muchas gracias. Muchas gracias.
Thank you very much, Dr. Felipe Torres, for your intervention. It's been very interesting. Now I would like to say, please bear time in mind. It's very important that you all adapt to the different times so that we can follow the program, the schedule, because there are many speakers. You can find the timing here in the screen. That's a message for all speakers, where that's a time that's decreasing. So that's all from my part. And next speaker, he's talking about a very important reflection. Is personalized medicine possible? So please welcome Dr. Giovambattista De Sarro.
Buongiorno signori, buongiorno signore.
Good morning, everyone. I would love to start by thanking Periso Academia Anfisaude for inviting me here today. We need to thank them because they allowed us to be here to integrate all our knowledge, and there's so many disciplines here in the medical field, and we're all here to talk about the diamagnetic therapy. So what is Sir William Mosler said from many years ago, if it were not for the great variability among individuals, medicine might as well be a science and not an art. So what does it mean? We've realized by using the drugs that some people need a whole pill, but some people need to reduce it, or reduce the amount of drugs, and they can have some adverse reaction. And this we can see according to the documents from the Egyptians. Hippocrates is one of the best known for this. And the first revolution of medicine is due to Leonardo da Vinci. He started to work with the corpse because before him, maybe because of Christianism, it was not possible to work with corpse, but thanks to these, we had some advances in medicine. So anatomy allowed us to discover some structures, and we have to also recognize the advances thanks to microscope. Very clearly, we have some more advanced microscopes. Pasteur was also had a big contribution by recognizing that there could be some pathologies in the cells, and also Pasteur started isolating the microbia and recognize diseases due to parasites. These discoveries are the beginning of a progress that allows us to live for many more years. And probably there is also another revolution. The third revolution could be the radiology. This allows us to analyze the patients in a complete manner. And what happened to the last 150 years? Well, all these really allowed to increase the life of people. This is antibiotics, CT scan, pacemakers, chemotherapy, oncology especially, and also randomized controlled trials with for different pathologies. So it is important to try to personalize the treatments to the patients, because obviously there is many different ways to cure them. There are some drugs that respond only to some variants of a disease, and also we have this systematic revision of meta-analysis that allows us to do a correct assessment of the different therapeutic approaches. Obviously, we also need to mention Fleming, who discovered penicillin, and this led to the creation of various drugs that helped us create many drugs. So many pathologies disappeared thanks to the vaccinations. For example, if we think of RNA vaccinations against COVID, and also we're now analyzing some vaccinations against cancer or Alzheimer. So in the past, you could die of AIDS, but now we all know you can live with AIDS. So this has been one of the big advances and results in the last years. This is now the elimination of hepatitis C. All the countries were concerned about the cost of the drugs, but in the end, the cost is quite reduced, and it's allowed to eliminate, in most cases, hepatitis C. So now we're gonna see something about biochemistry and biogenetics. This is the structure of DNA. And this helped us, the sequencing of DNA helped us to recognize the healthy cells, and also to discover some features of the rare diseases. And also this helped us to understand the features of some tumors, and also finding drugs that can replace the deficiencies in the DNA of those who suffer some diseases. So the precision drugs are something we can execute, and doubtlessly this brings benefits to many people. So this also helps us to have information on how to act in case we had some diseases. The magazine Time published this article some years ago about the right drug to use on the right patient for the right disease, and at the right time with the right dosage. Obviously, during many years, we have made a great effort to cure the disease, but now we need to cure the patient. So for personalized medicine and therapy, we need to identify various groups of patients. So we need to have a good prognosis, and also we need to, so that we can analyze the right drugs to use, and also we need to interact as early as possible so that we can understand the different factors and the family history, so that we can understand about the right treatment for a person. And we've discovered that through clinical trials designed in a specific manner, this is by identifying early biomarkers in subgroups of patients. This has allowed us to obtain information, very important information, that is in a genomic and proteomic data bank, also with other technologies, specifically different sanitary techniques. And so all this is made now by the new computers, and this allows us to gather a lot of information at a big scale, and this also allows us to see that the populations are different. So medicine also needs to be personalized also to different human features. So let's move on to the problem of the tumors. These are genetic changes, so after the time, this can accumulate, so the pathology worsens more and more. There are some genetic features that make a person run the risk of having this disease. So a preventive therapy and an early diagnosis will allow to face the disease better. So what we do is to use monoclonal antibodies that impact the tumor and not the healthy cells. So these are anti-tumor drugs. And this allows us to have longer life for the patients, and sometimes we can even cure them. So as the time passes and with the new knowledges, we can improve more and more, and we can produce new target drugs which are better. Barack Obama in 2015 already understood something very important. So the precision medicine, not just personalized medicine, this is a paramount to have a longer life and also to reduce the costs of health, which in the US is different as compared to Latam countries or European countries. For example, in Italy, it is much easier to access sanitary care. So what did we take into consideration? Beyond a general therapy, if we do not use biomarkers and if we do not do the right diagnosis, there is no benefit for subgroups of patients that didn't exist before. So how did we develop, or where was this developed best, in which fields? It was in the oncological field, but not only there. In some pathologies it was developed a bit less, but we saw already what happened with hepatitis C and AIDS. So these are now populations close to us. There are some metabolizers which are different. Some metabolize fast and some don't. So, for example, Spain, the Oriental population, there are big differences here. Some metabolizers, quick metabolizers, are different, or they didn't exist at least until now in Asia populations. So, what do we find these enzymes? Well, we find this, for example, in the liver, and this is affected also by genetics, or our daily habits, such as smoking or coffee, or the use of drugs, alcohol, and the industrial contamination pollution. So this can increase or reduce the effects of some drugs. So these are responsible in some cases for the increase or the decrease of the drug effectiveness. And this is also related to the central nervous system, and also this can be responsible for serotonin, for example, and this can also lead to codeine, for example, not being effective in a patient. This is a painkiller, and codeine cannot be transformed in morphine, for example, and genetic polymorphism related to these cytochromes can be protection factors, or how this can be done, and we'll see who can be the patient that can use this best. So all these drugs can be used in the right therapy for prevention. It can be personalized to obtain a better therapeutical effect and smaller intoxication effect. So we need to take into account many factors for personalized medicine. This is weight, body surface area, age, the organs, especially those related to the processing of the drugs, also gender, and also intestinal microbiome. So knowing all these data that are also used for the screening of the drugs, this is really necessary because this allows us to do the better clinical trials. So personalized therapy is always is the same as precision medicine. So most of the times this is about precision medicine. So it is also useful for the national sanitary health system to use this for later therapies, for better therapies. Obviously, personalized medicine is possible, but it is complex to implement because it will depend on what we get from the results from the lab and the biomolecular situation of the person. We can have also some early biomarkers. So we need to know the epigenomics, the genomics, and the symptoms and the microbiome, and all the data that we can have available. And all this will allow us to have the right diagnosis. And obviously, if we meet all these conditions, in addition to all the other parameters, there will be a better way to face the pathology, to fight the pathology. This is a study conducted in Italy, and we know that the heart risk factor patients, this is related to high blood pressure and diabetes, among others. So if we can control all these factors, we can have the patients adhering to the therapy. So if you see here, we had a reduction of the death rate because of our heart diseases. So this obviously improves the health of the patient. And we already have some very sophisticated genomic DNA next generation sequencing tests, or NGS. And also we have some other very advanced tests, which are single nucleotide polymorphism in specific genes, and this helps to dilute the drugs and also to eliminate later the drugs from the body. Here we can see the enzymes that participate. We can see here SYP3 and 4 for all the processing. So precision in fighting cancer, in oncology, this is the new battle. This is about using the right drug for the right patient. And this starts in the previous analysis. So here we can identify the right drug for the right patient. And of course, we have the big support, the big aid of computers. And also we have the so-called AI, because this allows us to have ecography and RMI and CAT. Through all that, we can have a structure of the pathology that we can analyze. And this is about the metaverse. Also, this is also very widely used in the surgeon theaters, in their work. So when it comes to personalization of medicine, we need to select the patients, and we need to share the results with the patients. So, for example, we need to understand that drugs should not be administered to a patient without explaining everything. We need to explain the whys of the selection of those drugs. So, precision health, this is for especially aimed at the health and the well-being of the patients. And this allows us to better understand that today's medicine is much more precise than what we had in the past. And I would like to finish by quoting Isaac Asimov. Science gathers knowledge faster than society gathers wisdom. And we all should take this into account if we work in health. So thank you very much. And well, the structure, this is the place we're working at Cansaro. This is our university. This is our 25th anniversary, so thank you so much. Thank you so much, Professor Giovambattista De Sarro. Thank you so much for sticking to the time. And please do not leave the stage and come now to your chair, because now we're going to start our first round table led by Luca Varelli. So please, also Dr. Felipe Torres and our engineer Antonio Lagatta. Thank you.
Bene. Allora, buongiorno a tutti quanti. Adesso partiamo con le domande. Abbiamo sentito questi...
Hi everyone, so now we have some time for Q&A. We want to listen now to, we've just heard these papers, so we want to thank everyone, Perisa Group, for inviting us. But now we saw that the group of knowledge is really important, or the whole of knowledge is really important, not just engineering and physics. So with this, everything can improve. So now we have time for Q&A. So obviously, I will not be the only one asking the questions. It would be great if you can also participate and ask things. So you can ask difficult and easy questions, quick answers. So Antonio, he's spoken about many things, how we improve and what a wave can do. But on a daily basis, sometimes we say, well, so let's do this type of treatment, and the patient looks at us and they say, well, I've already done diamagnetic therapy. So Antonio, what is the difference between diamagnetic therapy and magnetic therapy? So diamagnetic therapy takes the name from diamagnetism. So in order to obtain this effect, the magnetic field needs to have specific features. So for example, if we have some very quick impulses, if it's very high, then there is no surface, not enough surface. So then the pulse is too low, or the pushing is too low. So we need to add some features such as radio frequency. So together with the magnetic field, this works because there is a relationship between them, the both. So these rules build all this situation for this therapy. So yeah, this is diamagnetic therapy. Diamagnetic therapy is a bit quicker, so it moves the matter. So it is really important, as Felipe explained. Different patients have different problems, and that we need to manage, and the way we manage to treat. So normally we have a specific world where, on the one hand, we have genetics with different expressions and different data. So where is it possible to modify genetics? You talked about this. You talked, for example, about autism. So what is the role of epigenetics? And what is the role of in the modification of the genetics? So with all those these are all the aspects that we have. So we have some genes that have a short activation. This is for growth, the development of epiphyses, and muscle gaining. But normally pathologies in children, in this case, very specifically, there is an alteration in the activation of the process of development or migration or communication of a tissue. So mechanotransduction really takes, within the mithosis, they take a specific zone, which is G3. So with this modification of the mitotic division, so here there is a modulation of the normal response of what the cell should do. So epigenetics doesn't change the damaged gene, but they activate the genes so that we can have a response. So with dystrophy, we're not going to change. We're going to always find the same gene, but we're going to find an activation, a lateral or peripheric activation of the genes that can lead to a compensation of the dystrophin in, for example, in muscle dystrophia or muscle dystrophy. So with this, we can modify the genetic features of the environment to help the pathology we're treating. Great. So epigenetics is what conditions everything in the world. So all the factors that we receive can be modified in the body. So this is what epigenetics does. So with this we can modulate the professor was my teacher at university, so my question will be very easy for you. So personalizing therapy, what are we missing here? Because we personalize therapy, we hear all this all the time, but then we go to an office and then we're told, well, take this drug and take this drug because this is the same as someone else's drug, but we are different. So what is missing to have an objective personalization of the therapy? What is missing to get to that point? Personalization of a therapy can be done by bringing together different results. We need to know if we're talking about cancer or other pathologies. If we think of other pathologies, we need to understand the metabolism of the drugs and how the cytochromes work, or also how the transporters of the substances work so that we can choose the right drug for the right person. And also we need to take into account the age, for example, because we need to know if this drug can be administered to an elderly person or not. So clinical trials we do in healthy people, in males, in healthy males. We don't have so much data about women because women have just started to be included and the elderly do not participate in those clinical trials. So if we need to treat them, then that's the point where we start to see what they have and what diseases they have. And then depending on the diseases, then that's how we can try and cure them. I know this is not the perfect answer, but yeah. Someone in the audience has some questions? Yeah, there. I have a question for Dr. Gatta. You talked about diamagnetism. So where are we now and where are we going? I'm very interested in the part where you were talking about the differences between the peripheric tissues. So can you maybe talk about this? Because we use the machine a lot. So the patients are often asking, is this going to cause some damage or not? We always say no, but we want to hear your detailed answer so that we can deliver this to our patients. So now let's talk about what we're going to do. What we're going to do is we need to imagine how a machine can work in the future. Let's imagine we have a 3D image of the person. And I have this on my computer. I can visualize the 3D part that I want to treat. It could be a vase, or a tumoral area. I can draw on this part the volume that I want to treat. And when the machine starts, it will be working only on this area. And this is something totally different compared to other machines that we used to. Because with other machines, for example, even if you can design and draw the areas, all these areas are damaged. So there is an energetic distribution and a different distribution, but very clearly we cannot distribute the energy as we want. So there is a law, and we need to respect the law. Only the boxes that have a specific rotation can be energized. So it could be like 0. So this will be the future for the diamagnetic therapy, but with what we have today, unfortunately, diamagnetic therapy, and also like other therapies, it has to respect the law. So we need to have a distribution. We cannot do it different to the laws. So if we use the right techniques, we will not damage anything because we will be acting correctly. So Antonio, we were talking before about oncology therapy. In oncology, we always had the question, shall we use it or not? So in order to treat in oncology, we need to cause some damage, direct or indirect damage. It could be, for example, through a drug, but there is no other possibility. So right now, the magnetic field has an energy value, so we need to clarify, we need to build a fundamental law, and we need to analyze the shot energy equal to the frequency. So this would be like shooting against a glass or a ball or 1,000 of balls. It's different. So what we can do is to decide whether we apply a lot of energy on a ball or we distribute it among the different ones. So with CTU, we have energy distributed in various elements. So what we do is not changing the molecular structure. So what we're doing right now will allow us to maybe change to see if we want to cause the damage or not. And the unique covalent relationship rate is what we want to achieve, because we need these to change in the pharmacological ways that we can activate tumoral drug or to cause damages in the areas where we're interested. And this is all because we need to define in a very precise way the area that we want to treat, because otherwise we would have damage that we cannot repair. Alejandro is my name, from Costa Rica. Diamagnetic therapy, how can this impact exosomes and what results can we expect for the future? I think here we have two concepts. This is first, how do we produce an exosome and how do we introduce the exosome into the patient? So then the first part is about how to do a stimulation of the stem cells where we're requesting for those exosomes so that there is a specific modification, because in the exosome we find a process of RNA with interleukins and peptides, etc., and growth factors, etc., that needs to be conditioned. So these two forms, we have the normal excretion of the cell, or also the secretion that we induce from the cell. So we need to induce the right secretion. So also with complexity, we can have magnetotaxis, so that there is an increase of chemotaxis, and so that we can bring this also to the area. And this is being analyzed for long, and this is, we will obtain 72 hours after the stimuli of the diamagnetic therapy in the zone. And second would be implementing the exosome. So in the cell, it's very difficult to introduce into here. So there we'll have the exosome can actually penetrate the tissue and can penetrate different tissues, even very solid tissues. So that's the benefit of exosomes that we can have through diamagnetic therapy. We found some very positive results, but this depends a lot on the stimulation of the patient and on the exosome that we're having in order to place it. So for one more question for Professor De Sarro. Some organizations such as drug associations, are they already prepared to embrace all these into their randomized clinical trials? Can we create or build a standard process in this field to have a common use in the clinical practice? I believe that those organizations will find drugs to change the activity in the body with the combined use of the drugs with the diamagnetic pump. So this is something that is going to happen, and we will need some time for this. This could be like 1 year to try to understand what is going to happen. It is difficult actually to be prepared with the ethical committees. For example, I think they should include physical engineers to understand the application of all these. So obviously the doctors are stubborn, and it's difficult for us to change our opinion. So researchers we're a totally different race. But yeah, doctors are very stubborn. I also have a question, if I may. This is related to what we've heard. Is it possible to have a personalized therapy, taking into account also other technologies for the preconditioning of the tissues when it comes to having more of a vascular function, and also when the drugs can be more active? And if I'm not wrong, pharmacological research, this is always related to the cells, but we always forget about the matrix. I believe that the drug, in order to apply them, they need to change the drugs, because right now the drugs need to decide the area to be applied. So the drugs are sort of designed to respond to certain structures in the body according to certain features, but this geographical issue should be resolved by the machines, by the devices. So the drugs should respond to the device to change the way in which they act. So the drugs maybe will be similar in the future, but they should change the way they act. So if we can find a drug like this, we'll be able to resolve many problems. So we have 1 minute left. Well, in order to understand all this pressure that we're having here, we need to think of a spider web on water, in water or in a hydrogel. So when the spider is on water, it moves easier, but when it's on a gel or on a plasma, it moves with more difficulty. And this is just how the liquids move, and this is how there's an exchange in the matrix. So this manages for the drug to penetrate into the receivers or not. Like, for example, we're doing now a study for depression. This goes into serotonin, right? Well, no. We've detected in 100 patients that 80 of them, they have a high level of serotonin. So here we're doing an inhibition of the receiver of serotonin and not of the production. And this inhibition is because the matrix is blocked. There is an inflammation. That's how the problem comes. So the drug needs to be conditioned by the pharmacological process, microbiological process, and also the environmental condition with the right epigenetics, so the drug can work. Great, thank you so much. Do you have any more questions? All right, so we don't have much time. So regarding toxicology and regarding what we have just said, what can we do in terms of the movement of liquids? Can we use this machine or this device? Well, yes, we can use it to have a right answer. Yes, we can use this concept so that there is a quicker, clean response. Yes. So the last question to the engineer. All these can be applied to humans, but we live in a society with many animals, and many animals have problems of different nature. So all these can be applied to the animals. Well, this is a factor which is a medical factor, but we will have to maybe modify some aspects of the devices, because right now the devices are using the 3D dimension, so this should be replaced to be compatible with the different animals. And one very last question: anatomy changes. We have a very changing world, and the patients could have body mass of 18, but also 30, 33 with overweight. So what changes in the machine or the waves? Do they reach in the same way? What do we need to take into account to treat all the very different patients in phenotypic terms? So personalized medicine is very interesting. And of course, that's what we need to do. We need to adapt to the patients and treat them, of course, differently. So if they have overweight or obesity, of course, the results will be totally different with these different conditions. Yeah. Great. So thank you so much. Now, here, very last question. So what would be the main differences that you see between mechanotransduction and mechanotransduction with diamagnetic therapy? What could be the biggest difference? Well, it's very simple. If you touch spider web, when the fly is vibrating, for example, and the size changes, this is what these machines do. So this specificity in the spider web, it's different if it's on gel, on water, or in the air. So here we're being specific. So we're adapting the spider web to the different situations. So we're now closer to a personalized medicine. Yes, of course, now biotechnology, I think this is the only personalized way. Yes, definitely yes. Good morning. I'd like to ask Dr. Felipe, but now I'm very curious about what Engineer Lagat explained about other techniques distributing anti-magnetism by stimulating. So CT omega 20 with the different waves to work on the different tissues according to the different frequency of modulation. I was wondering, with the period of treatment for a patient, with the specific pathologies, if we use it for degenerative diseases or in the brain tissue, even though we're not going to change the gene, for how long could we use it with this patient, like a dystrophy or degenerative diseases? How long should we use it to achieve a change? And with Mega 20, maybe Engineer Lagat, maybe you can think, or the doctor can think, having the wave and the frequency for the time when the cell becomes a bad cell. So the example of Gamma knife, this is the specificity that we want to achieve with the diamagnetic therapy, 0.005 of specificity. It's not about the elimination of the gamma knife, but about the being specific. So we need to see how we can do. Well, maybe it should be, the treatment should be every 7 days or 8 days, so there is a change. So we need to achieve the exchange. So maybe after 8 to 10 sessions, we should be able to bring these to data once a month. So there is a change, and then every month, then every 6 months at the beginning, have the patients come in for 1 month or 2 months for 1 or 2 years, which is what we would do for working on neurology. Great, so thank you so much. So now the questions are over. Thank you very much. Thank you so much, Dr. Luca Gallelli, for chairing this session. So dear friends, now it's time for our coffee break. So the coffee will be in the hall. Thank you so much. And please, we'll need to be back after 30-40 minutes. Thank you.
Sí, sí, va, ahí está, fenómeno. Sí, va. Sí. Pa, va. Sí. Sí. Sí, va. Sí. Va.
Hola de nuevo. ¿Qué tal? ¿Cómo estáis? Espero que hayáis disfrutado de...
Hi again, how are you? I hope you had enjoyed your coffee. So now we are going to start with the second block of the session, which is about regenerative medicine. And before, I'm going to introduce all these speakers. First, Giuseppe Peretti, then Marion Schneider, third, Felipe Torres, then Pietro Romeo, and last in this block, which is the longest one, we will have Sebastian Truyols, and then we will have a table led, as you can see here, Felipe Torres, by Felipe Torres. He will be the moderator of the round table. So please come to the scenario, and thank you very much.
Hola.
Hi, can someone help me? It's very important that the presentation appears on the screen, otherwise people cannot work. Can someone help me? Okay, thank you very much. Okay, this is not what I was asking for. I just need someone that can project on the screen the presentations of the following speakers. Hi, hi. No, I don't want the guitars. Can somebody please help me? Okay, I'm not doing anything here.
dicen que tienes buen pelo y que te hace buen cojote. Y yo digo que es mentira, ay que son trapos que te meten. Caray, que caray, que caray, que caray, que minuto que gracia tenemos, caray. Y la hambre la vamos a sentir, que mira tú que gracia que tiene este país. Por caray, 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 que caray, que minuto que gracia tenemos el país. Ay, la hambre la vamos a sentir, que mira tú que gracia que tiene este país. Tiene tipo ta ta ta, 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 ta ta ta, vámonos.
Wow.
Wow. I guess that you have loved it, right? I hope you had enjoyed this regional dance that goes beyond the borders of Spain, and especially this is a very famous flamencos group. And now we're going to start. I would lie to you, if I said this was not scheduled. So now we are going to continue the session. First, we are going to start with the regenerative medicine. And now it's turns for Giuseppe Peretti with the current concepts in regenerative medicine. So a round of applause for him. Thank you.
Desafortunadamente tenemos que seguir.
Unfortunately, we have to continue with the presentations. I'm going to speak in Italian because that's my mother tongue. Thank you very much to Bartolomeo who invited me. I'm going to talk about some concepts of regenerative medicine, and I'm going to talk about the tissue. I'm a surgeon, and I've been working in this sector. In 1992, the regenerative medicine concept was presented. And we started 3 episodes: the gene therapy, cell therapy, and the tissue engineering, with the 3D bioprinting and in vitro meat. And when we talk about meat, about food, we need to talk about the FDA. This is the picture of given by the FDA with human tissues, with the cellular therapy, gene therapy, biological device that will be added to the regenerative medicine products. And I will talk about the cartilage tissue, which is an extraordinary tissue. When we have a cartilage injury, we don't have a standardized technique. So we try to avoid that or maybe postpone that. I'm working in the regenerative medicine, but I'm also working with prosthesis because patients usually come with advanced clinical cases. So the problems regarding cartilage might be 2 extensive lesions or focal lesions. First, extensive lesions is regarding OA. When it comes to the extensive lesions, we usually talk about orthobiologics. I need to thank these 3 women who helped me to conduct a presentation of this part. And I'm going to quote this definition of orthobiologics, that are organic and synthetic materials that can be used within the operating room and can improve the capacity of healing of the bone tissue. So regarding orthobiologics, we have to say that's not a definitive treatment. So we might reach anti-inflammatory actions, lubrication, or the reset of homeostasis that we are going to treat. It will also reduce the symptoms and it will improve the quality of life of patients. And those are our goals. So we need to conduct a cyclic treatment. That can be done through the PRP, which are platelet derived products. And these products that are platelet derived are products that contain a very high number of platelets, so they can increase that repair process. And there are many different effects. So we have an anti-inflammatory effect. They block the secretion of the cytokines, regenerative effect with an induction of the stem cell chemotaxis. And that allows the replacement of the damaged tissue. It has as well an angiogenic effect, an analgesic effect. And they induce a cell-mediated endocannabinoid response by reducing pain. And then we have the cartilage, which is not very hard. And then it has an antibacterial effect. So the main cell sources that can be used, we can talk about the PRP. The bone sources are completely different. We have the bone marrow, the adipose tissue, cells coming from the synovial fluid, and coming from different tissues coming from the fetus. So we have the umbilical cord, blood, placenta, and we usually use in bone marrow and adipose tissue initially. Now let's talk about the use of the regenerative medicine in cartilage. So we can say that these cells have an effect in the local cells that live in the tissue, and that's how we can increase the growth, the anti-inflammatory effects, and other effects. So there is like a renovation of these cells. So it's not necessary that these cells remain for a very long time in this tissue, because after that they will be working with the other cells. We know that these effects that we are talking about them do not last long. So that's why we need to use a cyclic treatment. When it comes to the application, we don't have the authorization. We have to say that they do not represent the first therapeutic choice. Of course, when it comes to the PRP, we are using it with younger patients with a lower OA level, and then we usually propose injections. And when it comes to the cell therapies, that's for older patients who have a higher OA level. There is no need to have an excessive BMI. Now I'm going to present this work we are about to complete. So this is data that we could gather by using part of the adipose tissue in one patient that had OA. So that's a work that I did together with many people, as you can see on the screen. So I'm very grateful for it, and thank you to all of them. So this is an open study. It's an experimental transplantation that wants to assess the benefits of an adipose tissue transplantation in the knee. So we've been working with 30 patients with knee osteoarthritis, OA, and we were working in 4 different groups. So we have the phase 1, that's the least severe patient, and the 4 is the most severe patient. We were working with patients from the age of 18 to 85, and we assessed the pain, life quality at 0, 3, 6, and 12 months. So we have a value, a number value regarding the life quality. We also conducted some phone interviews, and that's a work level as well. Phone interviews at over the 7, 8, 9, 10, 11 months. We also introduced the evaluation of some biomarkers for the regeneration of the cartilage, and we don't have definitive data, so I'm going to present the first results. So first we need to assess the safety and efficacy over 6 months, and then there are other important points such as the pain, life quality, and the long-term effect of life quality after the application of this product. Now, as for the inclusion criteria, there are many of them, but you can see in yellow the most important ones, so male or female patients between 18 and 85 years of age, pain level 1, 3, and pain level that overcomes 4 in a scale that goes from 0 to 10. They don't need to have other pathologies. They should not have other pathologies because that might have an impact in the treatment results. They should not have been treated with hyaluronic acid or steroids in the period prior to the treatment. And then, of course, we need to take into account some other pains that might impact the study. We know that the pain in another part of the body might have an impact in the pain in the knee. So we need to figure out that properly. So that's the procedure, the preliminary results. So we have visit 1, that's the previous visit to transplantation. And then we have visit number 2, the phone interview, and visit 4. So you can see as everything keeps improving, the feelings regarding pain keeps increasing and keeps improving. So after 3 months, that feeling was reduced and it was constant. Regarding the last group, we only have 14 patients, so the results are not always very significant. So that's CUS, that's an assessment test of the functions of the knees. So we can see that the results keep improving. Regarding the pre-injection consultation and a consultation after the 3 months. And it happens the same when it comes to the life quality of these patients, because there is an important increase, as you can see on the screen. So, these preliminary results, we might say that there has been a significant improvement of symptoms and functioning for at least 6 months after the procedure. There has been a reduction in pain levels. There are not negative effects, as you can see. So it's a sustainable method that's very quickly, that's very fast, and it requires time, of course. We have preliminary results. We need to complete them yet, but they are very promising. So we could use a longer experimental time. Now regarding the focal lesions, what are the current methods that we are using right now in order to treat the cartilage issues? So this is a very long list that I published back in 2011. And for a very long time, we've been having different methodologies. So this list is more complete now because we have more products and we have different solutions. I tried to do a small summary with a picture from the FDA. So, we need to promote the bone marrow stimulation techniques. We know that a repair process is very important. Cartilage doesn't have any blood, so we need to look for that blood. And then we need to transform everything with a process until we reach a cartilage tissue. So now we can see the microfractures. The clots that are present here and after 1 year, so we can see that there is a reduction after 1 year with this procedure, but it's not a long-lasting procedure. We have other tools. We have products, instruments that we can use. So here we can see the bone marrow stimulation by using biomaterials. We usually work with clots with different membranes. So this is a procedure that we've been working on and something I usually use. We can also use the cell therapy, and we keep getting from the metal the blood. We concentrate the blood from the marrow, and that's how we can get a group of cells. Then we will place in the membrane after that. So whenever I can see the injury, I can start with the treatment. And there are some tests that show the efficiency of this treatment. And as you can see, we can have a recovery of the tissue of the cartilage. We have other methods, such as the injection in the injury, or we can get the chondrocytes with an intervention, and with another intervention we can place the chondrocytes in the membrane. So this is a method that we don't use much in Italy. Because of reasons related to the law. Now I would like to talk about the nose to knee study. That's a study we conducted in 2020. And what's it about? So it's a two-step study, but the chondrocytes were not getting out of the knee, but from the nose. they were taken from the nose. That's a randomized multi-center phase 2 clinical trial. And now we're going to see what the phase 2 is. And that's a study for the regeneration of the cartilage lesions of the tissue. So here we have the results from this study. There were many people who worked on it. So we have surgeons and many others. So we can compare the tissue therapy versus the cell therapy. There are over 108 patients, age between 18 and 65. 65 is a very important age. That's a very advanced age for this study. So we conducted this study in 5 clinical centers, and that's a randomized treatment with an assessment after 24 months or follow-up. And then we can see the results that come from the different analysis with MRI scan, for instance. So those are the 5 centers in which we conducted the interventions. So that's a nasal cartilage biopsy. And if you talk to patients, they can tell you that it's very disgusting, actually. And then we have this sample, and we send that sample to the lab, where the chondrocytes are isolated, as you can see on the screen, until we obtain the cell concentration, and then they go to the membrane. And now we can have 2 types of results. We have 2 different results because some membranes, we were working on them for several days, and for other membranes, we were working for several weeks. That's the moment of the transplantation. That's the surgeon from Switzerland that worked with us over the first transplantation, because all transplantations were done properly and in the same way in all clinical centers. And as you can see here, the results are very good, because after 1 year, there was an increase of the coups in the 2 experimental groups. And if we gather all the data from different centers, and if we bring together the 2 groups, cell therapy, we can see an increase of the coups and coups overall, coups sport, the quality of life. And it's interesting to see the several revisions, because there were some patients who had been treated with other methods, and then we treated those patients again. So here you can see an injury after 3 months. So you can see that there is an improvement after 1 year. So this is the bone injury with the repair tissue that was created after 2 years of follow-up. That's another patient treated with osteotomy, but it didn't work. So we got rid of everything. We put a membrane. And of course, you can see that after 1 year and 2 years, the tissue improves. So here we have another patient with a repair after 3 months and after 1 year. And after 6-7 months, this patient could walk, and they had very good results after 1 year. So those are very promising results. Of course, those are preliminary results. We are still assessing if we should continue with an analysis of those patients for up to 5 years. So when it comes to the cartilage tissue, we have promising results as well. There is a lot of work ahead, but we are in the right direction when it comes to the diamagnetic therapy. I'm just here to learn. And of course, I would like to talk about my experience. And we have many interaction points with different and alternative therapies to the therapies that have been presented. So we can obtain very good results. Thank you very much for your attention. Thank you very much, Giuseppe Peretti, for your presentation. It was very interesting. Thank you very much. Next, we have a presentation talking about the functional properties, phenotypic properties, and metabolic properties. So please welcome Marion Schneider.
Gracias, Mario. Thank you.
Hello, everybody. Thank you very much for inviting me to this beautiful place, and I'm very much looking forward to what my presentation would look like in this wonderful screen. So we move from the joint into the cells, which are the cause of inflammation, and they also are the cause of degeneration. And I would like to present you some of our results, which are always addressing the inflammatory macrophage. So the inflammatory macrophage is something which is very important for the immune system because we need to generate inflammation in order to combat infections. Now, when that doesn't work properly, then you get disease, and I'd like to divide my talk into these 4 different points. And the conditions for activation of inflammatory macrophages are infection and certain cytokines, and these inflammatory macrophages are named M1. And they may generate other macrophages which do regeneration and wound healing. That is what we just saw in the talk before, and they are called M2. So the most important and the most severe inflammatory disease is this. That is severe sepsis, when the immune system completely deteriorates and there's only inflammation. And this disease can be treated in the most severe situation when we have septic shock by eliminating cytokines from the blood. And this is done by a so-called heme adsorption therapy. So you filter the blood over this column, which you see on the left-hand side, and then the patient may recover and he may also be able to awake and to talk to you. But the inflammation comes back, and this is still a problem. Now, what we do in research, we use these columns to isolate the macrophages. And as I said before, you have the M1 macrophages, which are inflammatory, and the M2, which are reconstitution, active, and regenerative. And we did this by putting different fractions into this column. So we used A, B, C, D, E, F. And in A, that is in the beginning of the column, you have many of these M1 macrophages, which make the patient sick. And in the final fraction, you have more of the M2 macrophages. They also look a little bit different. And there are many properties which make diamagnetic therapy interesting. And the one is that the M1 macrophages are full of ferritin. And you know ferritin is an iron product, and this ferritin makes those cells ferromagnetic, whereas all the other immune cells are diamagnetic. So there is a disbalance in sepsis. There are also some other properties. I don't go into that. But the one thing I'd like to mention is that you need inflammatory cytokines and products from bacteria which promote this M1 phenotype. But what we need for wound healing, we need the shift to the M2s, who have different properties, and they have a marker which is named CD163. And you also need a different cytokine profile that belongs to the biomarker story, that is MCSF, IL-4, and IL-13. You can forget about this. And when you would like to know whether a patient is in the M1 or the M2 or has a perfect balance, as hopefully everybody has here in this audience, because otherwise you would not function properly, then you can use a marker profile which we use for flow cytometry, and that is CD14 high, CD16 low, and we call these cells classically activated monocytes that circulate in the blood. And when wound healing is initiated, then you have another population which is CD14 dim and CD16 positive, has this funny name, alternatively activated monocytes. So you can identify any patient by this profile just by isolating blood samples and looking into them by flow cytometry. Now, when we get older, we all have an inflammation problem. And this inflammation problem is very much related to the stiffness of our vascular system. So that is also well known. And we try to transpose this stiffness effect by using Dynal beads, what you see on every of my slides. That is, these are iron plastic beads which are used for separation of cells, but we use them to stimulate our macrophages because they are rigid. And the macrophages are activated, and they are activated via a mechanoreceptor, which has also been introduced by Felipe this morning. And this, the expression of piezo-1 of this mechanoreceptor is different. It is very high in cytokine-stimulated macrophages, these ones, and you see the many green spots. And it's low in M2 macrophages, but it's positive in both of them. So you can, this piezo-1 can be activated, and the interesting story is that stiffness activates on the right-hand side with the inflammatory conditions. NF-kappa B, which is a mediator of inflammation, makes IL-1, TNF-alpha, IL-6. And here you see the activation of piezo-1, which causes a calcium influx. But what is not known, whether the piezo-1 also plays a role in the healing process, which is done by the M2 macrophages. Now, this is an interesting molecule, this piezo-1. It looks like a propeller, what you see on the right-hand side, and it works perfectly well to intrude calcium into a cell, and also other ions like potassium and cesium and barium. You can try many different things, and that helps signaling a lot. So you need to have calcium released in a cell to initiate a signaling process. And one of the most interesting processes is activation of macropinocytosis. So macropinocytosis can be done by macrophages, so they eat everything. They eat also detrimental stuff like aluminium or ions or some plastic particles and activate inflammation. That happens in many, many diseases, including tumors. And that can be activated by piezo-1, and you see a cartoon here. And the most important aspect is the upregulation of an F-actin cytoskeleton, which helps the cell to take up non-specifically material. And that can cause trouble. And we used, again, these plastic iron mixture beads to measure this. And here you see a small video, I hope it's running. On the left-hand side is a phase contrast. These are the cells. The blue is the nucleus, and the black dots are the Dynal beads. And you see that the Dynal beads attach to the macrophage, and the macrophage is then stimulated with piezo-1, and it generates calcium signal, which is called calcium flickering. And you can make this visible. I don't know whether you can see it. It's a bit bright here. That you have intrusion of calcium and initiation of signaling pathways. And what I would like to point out that these macrophages, they are from patients, are different. So there are some cells which respond very actively and others which have a weak response. That is due to the activation of piezo-1 by contacting the rigid particles. Now, what this stimulation also does, it causes the extension of membrane vesicles, which we call ruffles. So here you have an inflammatory macrophage who is sitting on a plastic surface, is stimulated by the plastic surface, which is also stiff, and makes this chou-fleur, the membranes, which are full of actin, and they can be used for uptake of particles. And when we screen cells from patients, we do this by this assay, and then we also run videos. This is not running. This is not running. Okay, it is not. So what I would like to, you have to believe me, these are just 2 cells from a patient, and the one is eating like crazy. That is the right-hand one. No, it does. Perfect. And the other one doesn't eat anything, but they are both on a rigid surface. So one can play with these mechanoreceptors, and I hope that you can play with it with using your diamagnetic therapy. And this is what we try to understand on a single-cell basis. So there's another electron micrograph showing the uptake of the dinyl beads, and they are taken up via the ruffle zone this here, and then they are brought into the inside of the cell. And inside, the material may be either degraded. Now, macrophages cannot degrade the iron plastic, but it can also be used to produce exosomes. And that will be the next part of my talk. And here you see just a video of another patient. You see a lot of these beads, and you see these macrophages, and they eat so many beads that you later on have a free room which is not having any beads anymore, and you can use this for mathematical modeling and writing programs. And we do this with patients who have glioblastoma, we do this with patients who have sepsis, and we do this with patients who suffer from rheumatoid arthritis or other autoimmune diseases. And in this cell, for instance, you also see probably some foam cell generation, and we all know from the medical point of view that foamy cells are very detrimental in disease. Then using image analysis, you can find out that some cells are more active than others, and if you have seen this cell here in the middle, you realize that they take up 7 to 10 particles at a time. And this process is only be explained by macropinocytosis, so you have activation of PSO1. So my last part addresses the macrophage communication by exosomes. So they eat a lot, they are stimulated by stiffness, they produce cytokines. And I think, and the most important issue, that both macrophages, the M1 and the M2, they secrete exosomes, and the exosomes are the language how tissues and immune cells communicate, because they bear a cargo, and this cargo can influence the transcription of the responding of the target cell. Now, the most important issue is that hopefully everybody of us still has some mesenchymal stem cells, which you can use to regenerate. We also heard that in the talk before. And this exosomes from the stem cells are always very positive because they counteract inflammation in the M1 macrophage, and they also promote the wound healing macrophage M2 without promoting tumors. And you can use those stem cell derived macrophages by buying them from companies, and you can also use this knowledge to study macrophages from patients. Like you see here in the electron micrograph, this is a dendritic cell, which we took from the cerebrospinal fluid, and the cerebrospinal fluid does not contain many cells, but it contains a lot of exosomes. And sometimes you find a cell like this one, and in this area you see the release of exosomes, and one might have the idea that this exosome release is also induced by contact to an apoptotic body. So again, we have the importance of the lipid raft and these microdomains to release these exosomes. And as I said before, a macrophage is able to take up all material by phagocytosis, but the most important and the most detrimental effect is macropinocytosis. So they take up everything, also the bad things, from body fluids. And then they generate the so-called multivesicular bodies, and they may be used to form late endosomes and secrete exosomes with a certain cargo. And in the good case, the microvesicular bodies, they fuse with the lysosome, and then everything is degraded. So when it's degraded, it's fine. If it's not degraded, then it can be used to make exosomes, good ones and bad ones. And here you see a magnification of the cell I showed before. This is necessary to have many other molecules which we need to study in further detail. One is the escort, and here you see that sphingomyelin, cholesterol, and tetraspanids are very important to load the exosomes. They can be loaded with good things and bad things, and we have concentrated to look into miRNAs. That is a product which influences transcription. So all the exosomes have a certain property on the surface. They also have integrants, so they can target certain tissues who have the receptors for those molecules. And inside, you have this result of the very difficult DNA and RNA sorting machinery. So this is just a few other pictures where we try to demonstrate what the cytoskeleton looks like. So you just take off all the proteins, and then you see these big vacuoles, which are due to macropinocytosis. And when you enlarge, you see that also the exosome release, or the macropinocytotic vesicles, which later on form exosomes, have an actin skeleton. So the actin skeleton is something extremely important to guide the release of material. And this is a scanning micrograph. When you happen to have some cells broken up, then you see how homogeneous these exosomes are in a certain size. And when you do trans-electron microscopy, then you have a certain fraction where you have vesicles which are non-specific and they don't contain a lot of RNA. And the right-hand side is a picture of the exosomes. You see the homogeneity of the size of the vesicles, and they contain this miRNA, which you can use for diagnostics. Now I come back to the patient where I showed you the column who was she was so severely sick and got hemofiltration, recovered for a week, but then got septic again, and she finally died. And on pathology came up with the diagnosis that she had an adenocarcinoma. So that's something we did not know, but we isolated the exosomes from these macrophages, which we got in fraction F, and we found a selection of miRNAs which explain that these exosomes from those macrophages from the patient promote a tumor. So they proliferate, they stimulate proliferation and invasion of malignant cells. They have been described to induce a tumor-like phenotype in glioblastoma, and the mirror 21-5P has a special signature for adenocarcinoma. So that is a diagnostic aspect. That's what we don't want. And now how can we inhibit this? And then I have to face you with another problem, and these are the so-called natural killer cells. The natural killer cells is something you are born with. You don't need a thymus or a skin or the gut to educate them. And these cells produce a lot of interferon gamma, but they can do another thing. They can also kill cells. And this is a killer natural NK cell, what you see on the right-hand side. It grabs into the target and introduces molecules like perforin, granzyme, and TRAIL, which finally causes the cell death. And here I brought another video where you see that NK cells can also kill macrophages. Here you see some round cells. These are ignorant lymphocytes, and you see the elongated ones. And they form a grip-like structure and target certain cells. And the macrophage at 12 o'clock has got some infectious agent. You can see still this moving. And on the right-hand cells are two macrophages which are just attacked by the NK cells and are finally killed. So every healthy individual needs those NK cells to control infection and inflammation every day in our life. And we looked a little bit into the contact zone between the macrophage and the NK cells, and they form a structure which we name a synapse. So the target cell, interestingly enough, makes the first connection to the NK cell, and then the NK cell can kill. So it's like in real life with the murder and the target. And this is just an electron micrograph, how you see, where you can appreciate how much interaction is there. The right-hand side, this is the NK cell, the right-hand one, with the grip attaching the macrophage, and you see the many ruffle zones of the macrophage, and this is infected, and it's a little bit more enlarged. And going back to our patients, this is a healthy individual. You just see the number of red dots. That is what we all should have. A lot of NK cells which fight any infection the first moment it comes up. So you realize sometimes that you feel as if you get a cough or a cold, and the next day everything is gone. And it's gone because these guys here in the middle are active. But our sepsis patients, they don't have these cells anymore. So they have only 5%, and the same is true for autoimmune diseases. They don't have these cells to control M1 and M2. And that is where we think we have the whole context. So we first have the mesenchymal stem cells, exosomes, which help to have the balance between M1 and M2. Most often they have to induce an M2 polarization. And when we look into the miRNA pattern of those exosomes, which stem from mesenchymal stem cells, we find a different set of genes, mostly those MIR10, MIR100 family genes, which regulate cytokine signaling. They help surviving stem cell survival, probably also active in chondrocytes, and they also promote the structure of intracellular organs like Golgi and endoplasmic reticulum. When you use these exosomes, you can put them onto inflammatory macrophages, and then you see another marker profile. So we have all our markers on the x-axis, on the y-axis and the x-axis, and you see the induction of an Fc receptor after 24-hour treatment with stem cell derived exosomes. So this blue population is going up. And you can also see that the anti-inflammatory marker, which describes the M2 macrophages, is increased in the presence of this stem cell-derived exosomes. So in the end, we think that exosomes, when they come from stem cells, hopefully also from our body, they help us to have the balance between M1 and M2 macrophages, by upregulation of certain markers, by a better response to immune complexes, because we all make antibodies and for elimination of infectious agents. They have an activity of piezo-1, which is the mechanically induced receptor, needs certain cytokines, and the process involved is macropinocytosis. So if this is shifted into the one or the other direction, then we have the chronic disease. And we definitely need natural killer cells to help us balance this by killing those cells who have infectious or inflammatory agents taken up, because this is recognized by the NK cells, and to induce a new balance. So I have to thank two people from my laboratory, and Duncan Ross and his team for giving me the stem cell-derived exosomes and the bioinformatics and sequencing we do with our core facilities in Ulm. Thank you very much.
Muchas gracias, Marion Schneider, por su...
Thank you so much, Marion Schneider, for your paper. It was great, all the images and videos, and an amazing explanation. Thank you so much. So next, before we move on, I would like to remind all the speakers, please, to stick to the time allocated, because we have so many speakers to the end tomorrow. So please, let's stick to the time, yeah? So the conclusions should be within the 20 minutes. So the next paper is Biotechnology in Regenerative Medicine, and we have Felipe Torres. Thank you.
Lo primero que tengo que decir es que
First, I have to say that it was Leopoldo Parada who was going to give this presentation, but he couldn't make it to Madrid, not even virtually, so that's why I'm here. First, I have to say that every time I hear the Dr. Marion Schneider about the functional properties, we can understand the PS1, that's what we were talking about in Mechanotransduction, has a direct effect on the stimulation of the inflammation process. So we are going to talk about it very quickly because we are running out of time. So we're talking again about regenerative medicine, but this type of medicine does not go by itself. As Dr. Peretti would say before, we will only talk about 3 parts, and we thought that we needed to have a whole rehabilitation, a group of medical staff, a project on biotechnology so that we have all these specialties. For 20 years, I've been listening that all different medicine specialties have a concept in order to improve the concept of regenerative medicine. It's not a person who is managing everything, but a specialist who gives the tool to the people responsible for it in order to manage the different specialties. I'm not going to talk about the different specialties that tackle the regenerative medicine, but now we have broader concept regarding regenerative medicines. We have nanotechnology, cell therapies, food therapies, stimulation therapies, amino acids, stimulation therapies such as shock waves, magnetic waves, intensity, diamagnetic therapy, intrabrain stimulation, and now we have a lot of cell therapies. We've been working with most of them, with different types of doctors, and we've been working with exosomes, with different tissues, with the umbilicus cord tissues, with fat usually, and with hetero cells, and with automatic cells, and of course, something that's more and more important in the personalized medicine. So we're talking about genetic exams, telomeric exams, specific exams, food allergy exams, neopeptides, looking for serotonin, in order to understand the internal changes that the patient is having. Studies, MRI scans, with ultrasounds, radiographies, and that's everything we are doing with the ultrasound. So when we have a world of regenerative medicine, we can see very good results. So we can talk about nanopharmacology that gives the induction of the growth factor that we want to have. We are stimulating a pump of information, but without any specific information. Then we have these cell therapies to stimulate whatever we want. Not everyone requires a cell therapy, and of course the Diamagnetotherapy as a preparation of the cell therapy and the stimulation process of it. So we have regenerative therapies, among others. We talked about it before, and of course we need to stimulate those stem cells that won't regenerate the specific place, and that's why it is very important to modulate everything. So that's the history of the stem cells. Of course, in 2014, we've progressed quite a lot. 1 month ago, we approved the first cell therapy by the FDA. So we have like the permission of the FDA. So that was very helpful in order to have different options. There are some people who only worked with bone marrows, others who worked with cotton jelly. Europe and the US work more with the bone marrow. So we have the experience of working with both, with very good results. But of course, what we were talking about, modern science, who said that there was more beyond these stem cells, that cells needed to have a communication, and that's why all this is present in all the ECMs, so that we can provide in this ECM concept, as we said before, 2 different tendons. It's a completely different matrix that doesn't have receptors at the neurological level, but aminoglycosacanos that stimulate the matrix. So what we have seen when we are using shock waves and genetic expression, that's everything we have seen. The activation of some genetic processes, the growth factors, epidemic growth factors, and of course the transforming effect, which is beta, and that's proteins in order to rechange that matrix and now in inflammatory process in interleukin 6. And that's what we've known so far in the traditional waves. And we have a different concept that we should be working with the diamagnetic therapy, with a capacity of stimulation for these cells. Of course, this will lead to a chemotaxis, a more support, and we are fighting for having the same patients with different cells. But for example, the bone cell in a person that's 80 that has more problems. And we have internal exosomes that are not very helpful for patients. So that's why we start working with other cells cotton jelly, for instance, so that we can do all these different processes for cell differentiation. So here, we can see in the different cultures that we have, when we put growth factors, they can start working together, they start getting all these ramifications in order to get adapted to this matrix. And that's the same when we do the diamagnetic therapy. So that's a specific preparation to have a better result that we have found in those patients so far. So that's with epidemic growth factors. We do the same stimulation. And we have seen that the epidemic growth factors, as it is a very quick replacement tissue, has a higher response. We have different growth factors responses. Of course, the mesenchymal stem cell is given previously so that a migration towards chemotaxis is taking place in the areas where we want regeneration, and these stem cells help them to adapt the results. So we have these very important phases. This is a pre-stimulation with the condition of nanodrugs, so that a modulation of the receptors of the cell membrane happens. We have an adaptation done with technology, biotechnology, diamagnetic technology, direct modulation with stem cells, and a co-regeneration that happens in the 18 months we were talking about. And that's very important to stimulate the cell we are placing. And the first 3 months are the most important. So it's very important to do the rehabilitation, and that's where we require the therapy more, because placing the stem cell in an infiltration, first that stem cell will heal the infiltration. It won't heal the damage produced by the damaged tissue. So the process of understanding diamagnetism from the specific concept to the universal concept. So we need to understand all these in order to improve the cell membrane that's in a process of hypermetabolism, and we need to control these electrical circuits so that the receptors have more latitude. I won't talk about it, Dr. Pietro will talk about it, in order to have some results. Bear in mind that biotechnology does not come. It's the process, it's the result of the concepts that we've been using in different fields, such as transportation. So it's very important for you to remember that we don't need no unpaired electrons. So that's why we don't need a lot of time, and we don't need an acidotic tissue. It can be alkaline tissue, and it will provide a response within the things that we are looking for, same function. We are working on water, on biological tissues, calcium, and fatty cells in order to conduct the expression. So this is the disassociation that we can check on the misantropy. And we were talking about it in the previous conference. And here we can see the message signal to enter in the osmotic pressure of the tissue we are looking for in order to treat all these. So those are the biomagnetic characteristics of the tissues. This is the fluids process, but it's very important in this condition to mention the molecules transplantation in order to work on what we're working. So that stimulation is very important. We can see that we have some cells, growth factors when they are in culture. We also talk about the chemotaxis in the billion of cells that we have. Then we have the magnetotaxis that has a specific element, and it's very interesting to see that chemotaxis is powered by electromagnetism, so that tissues such as cells can arrive. For example, in Asia, the cells are implemented in an intravenous way, but here in Europe we work in different ways, and we can see the organ that we want to regenerate. So that's why we have a paradigm of different pharmaceuticals, and we can work with all of them. And of course, we need to talk about the implementation that was explained by the doctor. When we place exosomes, they have a very good results, and we got very good responses. When it comes to managing the inflammatory process, I won't talk about it. The intracellular union of FV beta, helping the time junctions in different tissues, including the hematoencephalic barrier. So we can find a control within self-immunity, within the control at the cell level. That's one of the most interesting studies that we have. And they were very interesting. They got a very interesting process. When the athletes were injured, you can see that the response is quicker. It makes it to the same area, but quicker than what we already had. And that happens as well in the vascular injuries, in ulcers. Of course, when it comes to the molecules implementation, we did a very good study at the university, and we can see that molecules don't change. They are implemented and work better. They have no side effects, and it powers the drug's activities in the area we want to work with. So, of course, in the future, we want to work straightforward in the laboratory so that we can make a differentiation regarding the tissues that we need on diamagnetic therapy on different cultures. Of course, we need to work in 3D cultures. What do I want to show to all of you? When we're working all together, I mean, those are just studies. I want to show you that we are working in degenerative bone muscle diseases, fibromyalgias, Alzheimer, backbone injuries, herniated disc. We have pain, neuropathic diseases. When it comes to the bone muscle degeneration, we have some arthrosis, among others. And that's everything we are doing with patients. That's the full process we are doing with patients. That's the application that's directed to the treatment we are working with. And of course, we also do some cosmetics treatments. So for example, those are people who have diamagnetic transplantation. I won't talk about these cases because this is just a aesthetic component where we can see there is an improvement in the skin injuries within the crinkles that might appear. For example, if there is acne scars, they get better after the diamagnetic therapy. And there are some exosome cases. For example, we have the case of a patient who was 88 years old, who had a very important heart attack. And when we started, she had 55 arrhythmias in 24 hours. After 2 months of the therapy, she had less, and we could manage a lot of the arrhythmias. So this is a boy with the West syndrome. He could not move, he could not move his head, he was totally hypotonic. He had some convulsions, some seizures. So you can see the first pictures after these transplantations. We started with the diamagnetic therapy. He had no possibilities to survive. So he has very good responses. So this is a guy that had a stroke. He was blind. He could not move. This is the same guy touching the kitchen. A very good visual response, let's say. So this is a patient. He was a Coca-Cola commercial director, but he had a problem. I won't play the video. He was 47 years old. He could not move. We had to put him in the bed the first time he came. This patient, after 6 months of treatment, has better control, and we have a lot of expectations on his response. So thank you very much. Thank you very much. Thank you very much, Felipe Torres, for your intervention. It was very illustrative and very well explained. It was very interesting. So now we have another conference. from Pietro Romeo, from the Physics to Biology, Artificial Intelligence and Diamagnetic Technology. So please welcome Pietro Romeo.
Interessante però.
Di biofisica, istintivamente pensiamo a un concetto molto semplice che è l'applicazione.
Thank you so much. When we think of biophysics, we think of something quite simple. So this is applications of science or physics to biology. Is this a reality? This link, this relation? Well, yes. This we can see in many fields in physics, IT development, nanotechnology. So right now we need to better understand how to define biophysics. Normally we define this in a very generic way. This is science of life, because there is a correlation between what is physical. So we know that we live under a certain electromagnetic umbrella. So we need to worry also about other topics. Like, for example, when we see these equations, we worry a lot. But to be honest, the important thing is that we clarify the simple concepts, which are the ones I'm going to explain now. So this is a typical example of complexity. So when we talk about the magnetic concentration gradient force, here we can see an equation to see the concentration of forces in a spheric element within a static magnetic field. So the X here is very important because this represents the capacity of the matter to magnetize. So thanks to this value, we can have a more or less diamagnetic effect, or just not have it at all. So it is very important to consider or to try to define certain aspects. We've already talked about mechanotransduction and also shocking waves or shock waves. So all this defines different metabolic processes in the cells. This is metaphysics. And we always have two aspects. We have the biological effect with the levitation of the frog here, or also of the trains. And this is all the same principle. So Felipe Torres also explained about some structural differences in diamagnetic therapy. So here we can have electrons unaligned or non-paired electrons, and this has an impact on the electromagnetic fields. And the alignment here of the spine cord. So what happens here in biophysics beyond the extracellular membrane and inside the cell? This is what happens also in the membrane. So here we already know that there are some mechanisms of transportation which are very important. So let's start now with the Faraday law, because he identified a long time ago that a variable magnetic field with an electric circuit could allow for a magnetic movement of loads. So this is a variation of potential of the membranes. And Lenz found out later that this movement, opposing flows of ion and molecules with require a high intensity magnetic field. So the applications of the magnetic field are related to the interferences. So we've been analyzing all this, and this we already saw with Felipe Torres. We see here the regeneration curve. And we analyze this fish for today to analyze the highest capacity of regeneration with the fishes treated with Diamagnetotherapy, and those that were untreated. And we see here the different limits, and there's also some limits in our diamagnetic therapy. The good thing about this therapy is that we're made up by diamagnetic matter, especially water, and all these ions that are part of the normal metabolic processes. So now when it comes to plasticity of the cells, this can change depending on the variations of the different potentials of the membranes. Also, we need to take into account the behavior of the mature cells. So this is now related to the polarization of the cell, and this can lead to different effects. So in this case, calcium is very magnetic. And we can see here, and this is very relevant. So now when it comes to diamagnetism, we have three key concepts. We have intensity of the magnetic field, that's allowed by diamagnetic therapy, also the gradient of the magnetic field in time and space, and also the possibility during the therapy to release multi-frequency bands. So this is not our frequency of the magnetic field, but electromagnetic frequencies that go with the signals of the diamagnetic pump. So the capacity of the cells to react to the effects of the diamagnetic field, this is quite interesting, and we can never define the response times of a cell in a lab, and this can be a difficulty for researchers, but we need to be patient, like in the case here of the fish. We had to conduct different studies to have a response regarding the magnetic field. So this is due to the different response times of the cells. And we can see here with calcium and potassium, we can see here that there's different timings when it comes to the potential of the membrane with the magnetic field. So with this, we can guide the ions through the cell. And in the membrane, we have some diamagnetic substances. My apologies, I meant some paramagnetic particles that do not respond to a diamagnetic therapy. So this can have some consequences on the basic mechanisms for the functioning of the cells. And we can see here another study, and there is a difference here. To the left, we see paramagnetic substances, and to the right, we see diamagnetic substances. And we see the molecules distribution inside the cell, and inside the cell, we have a continuous displacement of diamagnetic substances. In addition to the intensity of the magnetic field and the gradient, we can also see some other transformations in time and space, and this will allow to see some different drawings of the waves. For example, here in triangles, these here, for example, were approved by the US Drug and Food Agency. This was approved as a diamagnetic therapy. And this is very interesting, this possibility of changing the amplitude of the magnetic field. If we select here during the therapy, we can see how the extracellular membrane is working more, but we can change the wavelength, and this allows to activate a set of mechanical processes within the cytoplasma beyond just the ionic flows that we saw before. Engineer Gatta explained before about this concept. And this is what happens at a cell level. This happens constantly when the cells are impacted by a big amount of energy. And as a result, we have a frequency in the tissues, as we saw before in the images. We've already talked about the possibility of having various magnetic fields, because in all the technologies, the rise time here, like in the shock waves, this is paramount. So with a shorter rise time, we can reach our target quicker, so we can have diamagnetic energy applied to the tissue. But as the engineer said, here we'll have more possibilities to have some substances in a transdynamic way. So here we can see another anti-inflammatory study in also in nutraceutical studies, but we were not able to see, we didn't see any changes in the molecular structure here. So this means this is safe. And we've also seen, and we've analyzed the possibility of applying AI. So this was thanks to the contributions by Turing. So this is a test saying that the more similar AI is to humans, then the better it will be. And we are already applying AI to the technology, to the Diamagnetic technology, because this is a non-invasive technology. It's not complex, and it is efficient, and it is quite safe. And additionally, in our clinical history, we have two possibilities. We see one here, the clinical trial, and also we have the conventional clinical practice and also the different patients. And at the bottom, we can see a new possibility, which we will like more. This is analyzing an algorithm and making therapeutic decisions based on that. So this cannot be applied if we take into account all the advantages of AI. So here we could, for example, gather data according to the different standards and the different types of tissue, the patient and possible diseases. So we can gather all those data for the Diamagnetic technology and also for shock waves technology. And we can modulate the energy through the different parameters that we can set up. And we can gather all those data. And after gathering all those data, we'll grant the possibility to create protocols for reference. And those protocols, you do not always need to follow 100% because we know our clinical practice. So we need to continue analyzing the patient and the response of the patient. So as a result, we will have a process of curation which will be much more efficient. We have a more efficient healing process. So AI will help us with data processing, and this will also help us to treat our patients better. Thank you very much for your attention.
Thank you very much, Pietro Romeo, because you stuck to time and the talk was very dynamic. It's a pleasure to listen to you. So next speaker is a recent lover of the diamagnetic therapy. He's very well known in Spain, and he's one of my friends. So he's Sebastian Truyols, and he's going to talk about the physiotherapy and sport deconditioning and diamagnetic technology. So welcome. So good morning, everyone. First, thank you very much to Paraiso for inviting me to take part in a very well-organized conference. Congratulations to all the previous speakers, because I was shocked. I listened to Felipe Torres and many other colleagues, and I'm very, very happy with the speakers, with interventions. So my presentation is more focused on the diamagnetic pump. Why am I using it every day? What are the benefits from it? And I focus on the soft parts. I really enjoy working with athletes, and I think the pump is a great equipment to help our patients and to accelerate the process. So we are going to see how we can use it with soft parts. So what are the contributions or benefits from the diamagnetic pump for the treatment of soft parts? We're talking about tendons, muscles, and all the things that the pump can provide us. And I've been working on it, and I've been trying to get scientific evidence in this regard. So last year in Lugano, it was my first contact with the pump. I realized that patients with the tennis leg, we could speed up the process in those hematomas in which doctors would rather not extract that it had hematoma. So for example, with another machine such as diathermia, we would try to do all the processes, but we would find patients that had been having the hematoma for 2-3 months. And I was amazed by the capacity of the pump, because with just 1-2 sessions, we could move all the fluids. And that's how we started to see the great possibilities of the pumps. For example, in this case, it was a patient who broke his inner calf. Doctors didn't want to drain it. He did not evolve with other techniques of physiotherapy, and we realized that with the pump, thanks to the ultrasound, the results were very good. So that hematoma that was becoming a problem, we would get an evolution. So we did a poster, like last year, we couldn't make it to, I couldn't bring it to Lugano. So that's the poster for last year in Lugano. So that's a patient with a hematoma that could not move. And thanks to the pump, we could see some results in just 2-3 sessions. The results were amazing. So we can see that the pathology that usually happens in the lower limbs, I've been working for many years with football players, with athletes, and we could see that many pathologies would happen in the lower limbs. And the pump is a great tool in order to get quick changes, and so that patients could recover quicker. So in acute phase, the pump will accelerate the processes of recovery, will accelerate the tissue regeneration, and we will be able to adapt to all different phases of the injuries. Okay, so what are my goals? We want to improve the different tissues, decrease fluids, reduce the deadlines, and we want to prevent potential relapses. So we've seen all these, the great benefits from the pump. It's very important in the biostimulation of the damaged tissues. I can use the frequency that I prefer, fluid displacement, and that's going to be very important in the inflammatory process. Other benefits, we can accelerate that process. The fact of being able to drain with the pump. We have diathermy that's associated with the pump. Or even though there is no contact, for example, yesterday we treated a professional player. She had an injury in her ankle, so we could use it in different cases. And there is a stimulus in different biological processes. For example, we found a great hematoma, a big hematoma in the leg, and this might lead to different problems. So we have two options. One of them is that we can talk to the doctor, and the doctors can drain that hematoma, or maybe we can use other means. For example, I think that the diamagnetic pump is going to provide me with very good results. Of course, it's the doctor who is going to decide, but I can find many good doctors from Madrid that usually say that first we should prevent draining the hematoma because this might lead to infections, and if that's not the case, we can drain it. For example, yesterday we had like an inner calf. I saw an inner calf that they are not having the best treatments and they are having many problems. I will play you a video. So what we are going to do is like from this hematoma at first phase, instead of draining the hematoma, we are going to use the treatment of diamagnetic pump. I love working with athletes, but I also work with normal people. For example, this is an older person that fell down, an old person, and this person has a very big hematoma and we have to drain that hematoma.
Usar la capacidad de la bomba con programas de líquidos extra high, intra high para drenar. En este caso no tenemos un hematoma muy grande con toda la pierna.
She can't walk, she was using a wheelchair, and we start using different programs that help us drain all those things, and that's how the patients can recover themselves. But we are not only using that in patients who have some injuries. For example, this is Eva. She was using the treatment of the pump with us. I think she's dancing tomorrow in Vasov. She's a professional dancer. She doesn't have a concrete injury, but we are accelerating the recovery process. We want her to get better in those moments where she feels some pain. And as we will see on the video, so we want to accelerate the recovery processes in those elite athletes that don't have a lot of time for their recovery. So we can see Eva, and in this case,
Bueno, vamos a ver un caso que deportistas y
we are
profesionales, como
draining
es el caso
her.
de Eva, que es bailarina profesional, donde la bomba le vamos a sacar un buen partido para todo el tema de lo que es drenaje. En este caso, ella no trae ninguna lesión concreta, sino que queremos, tiene que ir a bailar, y entonces lo que queremos es drenar todas las piernas. Para ello le vamos a meter el programa de líquidos, ¿vale? Intra-high, extra-high.
So we are going to start with fluids that can be associated with diathermy. We put 3 for diathermy.
Entonces,
and we start with a program. So within my treatment, I will be able to use the pump. And the feedback from the patients is that it really works. Actually, Eva is becoming addicted to the pump, and every time she goes to a show, she has to dance, she comes for a massage session or a draining session. For example, we can see that not only in the cases where there is an injury or when there is an inflammation, but actually for the setup of the different athletes. So this is the case of a triathlete, and he has a good tumor in the nerve, a schwannoma. So he feels some pain, he feels that he has like a bulk, and that's why he cannot compete in a normal way. And when the doctors analyze that, they realize that there is a good tumor, and that's very important because we're not going to use the pump in bad tumors because that affects the metabolism and we don't want that. But for this process, they opened the area, they cleaned the area, and the patient comes. So the patient comes with crutches, and the pump was very helpful for him because we decreased the pain. So this is a test where we say that there is a solid soft tissue tumor, and basically they want that area to get dry. They operate that area, and we can find that the patient, we are going to start treating the patient in order to accelerate the process of recovery.
Es una lesión bastante rara, de lesión en nervio. Él notó un bultito y pues bueno, pues le han tenido que hacer, vemos aquí que le tuvieron que, pues esto le tuvieron que intervenir. Entonces aquí tú ha tenido bastante inflamación. Es un paciente además que ya nos advirtió que él cicatriza, que no cicatriza muy bien. Por tanto, le venimos haciendo bomba con muy buenos
So he was
resultados.
saying that he was a person whose scar process was not very quick, so the pump was very helpful for him. So now we are working in the pain part.
Ha pasado de tener muleta a necesitar la muleta, quitó rápidamente la muleta y ahora las sensaciones fue revisado por el doctor y son bastante buenas. En este caso la bomba nos ha ayudado mucho.
So he was using scratches, he's not using scratches anymore, and the feelings from the doctors and the patient is that he progressed very quickly and that he's doing very well.
Y luego todos los mecanismos de dolor. El paciente ha notado una mejoría bastante interesante.
So those are some cases. You know, in just 1 week I recorded 3 videos, but I've had more cases this week. Now I'm more focused on using the pump with fluids, and I'm recording some videos in order to get some scientific evidence so that we can see that the pump can move the fluids. But the possibilities are thousands. Like, there are people in the clinic who are using them for pain, for the pelvic floor. I focused on the lower limbs, but I could have taken more videos because we can see that the results are working and are working very well. Okay, so I wanted to share with you my idea of the pump, of how we can accelerate the processes, and thank you very much for your attention. Thank you very much, Sebastian Truyols. It was very interesting. Thank you for keeping it short so that we can stick to times. Wow. Great intervention, great presentations. It's been great to be able to listen to you here. And I'm pretty sure that you have many questions and you want to know more. So it's the moment for it because we have the debate table and all the speakers from this second block are coming. So please, Giuseppe Peretti, Marion Schneider, Felipe Torres, Pietro Romeo, and Sebastian Truyols are going to be taking part in the round table, and Felipe Torres will be the facilitator. So a round of applause for them.
Muy bien.
Okay, thank you very much. I think it was very interesting. I don't think time is enough for the amount of information we are having, and especially when we are talking about regenerative medicine, diamagnetic therapy, different processes. We're running out of time, so we're going to start right straightforward with the questions. And if you don't have the questions, I will ask some questions to the speakers. So who wants to start? Who wants to start? Am I wrong, or do you understand everything? Okay, nobody. Felipe, I wanted to ask you, what's the difference that you have when you worked only with stem cells and diamagnetic therapy? So we got 3 things. We're going to talk about the final results and what we saw on the way. So first we had a patient with a good preparation, with patients would have the same symptoms, with a neurological adaptation, and we had to wait 3 months for great changes, crises, inflammations that would happen 20 days after that, 1 month and a half after that. So we started with the repair process. And now we have a situation where I come here and I say, should I put the betas? Because should I put the cells? Because it was better before the cells. So we want cells to make a specific change. So the answer we were expecting for 6 months is an answer that we are finding in just 2-3 months. And the specific answer of the tissue that we want to find in the cells are higher. So we have better results. And I have previous patients older patients that bring new patients, and they say, why are these patients doing better than me? Well, nowadays we have more technology, and thanks to the diamagnetic therapy, we can deal with the chronic stabilization and acute phase. So yeah, that's it. Any other questions? So my question is for you and the Dr. Schneider. We can see more and more patients that are BH positive with food, with nutrition states that are not the proper ones, and they have a very high viral load. So I can see that everything is very promising, but my question is, what can we do with it? And what can we do in order to increase the TC4? If you take a look at it as a biostimulation, like if you can stimulate an area, we can make a difference between the different responses. Because what happens is that we can get a regulation process so that there is an increase of the CD8, CD4, but of course, the CD4 are there stuck in a viral process. And that's what we are seeing in the cells, and that's why the cell therapy has shown several health processes that suffered a change. And personally, I think that the last article talks about asthma in the reactive process DH2 and in the processes through mechanotransduction. I think the future of mechanotransduction is not only mechanical, but it goes from hormonal, neurological, and also muscle aspects. You can ask a question to the Dr. Marion Schneider in English, if you want.
Wondering, in cases for physicians that treat HIV patients, positive patients, and the ones that we treat are, in terms of nutrition, not that well nutritioned. When we treat them with the antiretrovirals, they respond to it. The viral load is really low. But in terms of TCD4, they don't really go up. Is there anything that we can do about it with this technology?
So, can you repeat the question, Philippe? Can you repeat the question for me?
Basic is the problem in the treatment with the patient, the VIH positive, is the problem the CD4 is inclusive to the cells. Is possible the new technology stimulate the immunologic system for the response, the CD4 and CD8? Yeah. Is your thing is possible?
Absolutely, very, very, very good question, because that is where the fascial tissue and the myofascial system comes into play. So, because these fascia can produce the cytokines which play an enormous regenerative role for the cells which are maturing in the gut. So we know that adult people can regenerate the immune system from the gut, but they need the cytokines from the skeletal muscle and from the fascia. And there's one molecule with the family which is named myokines, and also the interleukin-15, which activates the NK cells. And then you can regenerate the CD4 naive T cells which come from the bone marrow, and they are educated in the gut with the help of these cytokines, and then you can generate a new immune response and combat the old one which makes you sick. This is exactly, that is my personal interest for this whole community, although I don't speak Spanish, I understand a little bit, but this is my interest. So there we need to have the myofascial therapy for the cytokines, and then we can educate the immune system, and then we finally can combat this chronic inflammation related to, in the end, it's the macrophage, and also inhibit these ruffles, you know, when they make the ruffles, then the problem starts. Yeah.
Thank you very much.
Thank you very much for the question.
¿Otra pregunta?
Any other questions? I have a question for Sebas. When it comes to fluid displacement, the results are only with diamagnetic therapy, or thanks to the combination with diamagnetic or the capacitive therapy? And if you combine, how can you choose the placing of the electrode? So in order to displace fluids, I prefer doing it with diathermia. So you will have the effect of push and pull. Like if you have a diathermy in the clinic, at some stage, we talk about 6-7 minutes where the system collapses, it's overwhelmed. So one of the advantages that I was told, the specialist of the pump, is that there is a push and pull effect so that the system is not overwhelmed. So that's going to be very beneficial, and that's going to help you a lot if you do it with the diathermy. I use the pluglets, like for example, I'm doing a massage with the diathermia, I put it underneath, but I usually do like a cross, because these experts, such as Iria, I usually get the support from Michaela and Iria, because they have been working with a pump longer than me, and they are more experts than me, and they explain that we should not have those distances because the effect would be better. So it's better if we use with the diathermy, because you will get an effect, and you can see the fact that very quickly. For example, the other day I was working with a woman that had been bitten by a dog, and there was blood, and in the same session you could see that there was a small line where you had been treating her, and externally you could see that the person had drained perfectly. And of course the results, like if there is an injury in an ankle, you can start using diathermy with a pump, and patients tell you about it. They feel that they are doing much better. I would combine that with pain programs, and there are patients that we reduce pain a lot, and you're accelerating the process a lot. I think it's interesting to keep playing with the tissues, with the times. I'm learning from the pump. I'm still learning from the pump. So I'm asking the people who have been working longer, because you can design your own programs and you can see specific injuries, how you did with them in order to drain fluids. Of course, I recommend diathermy. I'm going to ask one question for the two orthopedists that we have when it comes to managing stem cells and the diamagnetic therapy. So in regeneration, in a tissue that's 70% damaged, it cannot be regenerated because it cannot create stem cells. But I've seen that, for example, when we need to go into surgery, when there is a shock with the stem cells, there are some changes regarding the response of the post-surgery. So, for example, you have put some cells, some shock waves, that there is a better post-surgery response, and how long for that? So we have no experience in the pre-surgery treatment. In the groups we've been using are groups with a degeneration that was lower than the 4th grade. That's why we wanted to reduce the pain if it was possible, and in case of a lack of treatment, we could go into surgery. What we've seen with the stem cell treatment is that there is a very good response, and we can postpone the surgery. But it is interesting to see if the cell stem treatment can improve the response. But there is a technical part. And we prefer not injecting anything within the knee or the joints 6 months before the surgery, because we don't want to increase the risk of infections. I've been an advocate of the pre-treatment for injuries. In the starting phases of the arthrosis, that's what I use. And we should use it beyond the technology of shock waves. We should use it with the diamagnetic therapy. We can activate several mechanisms, especially when there is a physiological fluid towards the cartilage. In some cases, it might be difficult to reduce pain in patients. That's why a pretreatment might be useful before the implementation of cells. So, for example, we had patients that request the treatment, even though they don't really have the option, because the joints are very degenerate, are very bad, but after the surgery, we can see that the recovery process is much better, higher. I don't know if there are any other questions. So, is everyone hungry? I guess so, right? Okay, thank you very much. Now, time for lunch. Okay, thank you very much. Thank you very much. Okay, thank you very much for your attention. We are at the end of the second block of the session, so it's time for lunch. So could you please leave the room? Outside, there is some food. So please be back at 3 p.m. We can start again. Thank you very much. Please enjoy food.
Buenas tardes a todos.
Good afternoon. I hope you enjoyed your food. Now you're feeling better and you're very excited to start with the third session, which is very interesting as the previous ones. But first, before we continue with the conference, I would like to give you a surprise note, something for what the Parisa company has been working on. So please, Dr. Felipe Torres and the engineer Antonio Gatta, welcome again. We want to understand a little bit what's happening, and I want to ask some questions to the engineer Gatta. Currently, the global population is saying that after 50 years, the 50% of the population will have Alzheimer or a neurological disease. That means that there are many situations that we won't control. The drugs for Alzheimer, Parkinson, have been in the market for more than 20 years, and we have not seen a very good response. It's only about identifying the disease. But we can see that the autism has increased. Now we're talking, we have 40 in 1,000 births, and now we have 400 in 1,000 births. The problems of depression have increased, and the complexes of neurodevelopment have increased as well. So I would like to ask the engineer, what are you doing to fight against this?
Treatment doesn't exist really many other technology. Obviously, we have something here, but I don't know if you want for me to spoil right now the things that we have.
Perfect. Ahora estamos.
So, in the world, we are doing a therapy, a new therapy, a radiofrequency therapy, which is a transcranial therapy, and it had very good results. And even the Global Alzheimer Association has said that they can use that technology, and the American College of Transcranial Stimulation talks about the different therapies. What's the difference? What's better for the diamagnetic therapy in comparison with other transcranial technologies?
Sort of very strong magnetic field with a very short rise time. So in terms of the frequency, we have a lot of frequencies. But into the diamagnetic therapy that we have is different approach. So we have not only the rise time, but we have also a plateau. Because typically, when you see this kind of problem, there are two different approaches. One is in the time domain, to just see the waveform. Another one is to see the same problem in the frequency domain. When you see the problem in the frequency domain, you observe many other effect of the diamagnetic therapy. For example, during the rest time, everything that is short in time is wide in spectrum. Spectrum means frequencies. So then we have the first part of the pulse that is very short in time, this wide in frequencies, very wide in spectrum. Then we have a plateau where we have different spectrum, and finally we have that full time that it's a different spectrum. So the spectrum of the machine is so wide and changing moment by moment. Another interesting thing is the way to concentrate this energy in the deep into the brain. It's very well known that the magnetic field is different than the electrical field because fall according to the cubic law. It means that it's enough to reduce a little bit the distance that the force, in case of the magnet, but also in case of the magnetic machine, drastically reduce the power. If you make 10 times the distance, the magnetic field is 1,000 times less power. So in which way we can compensate this effect? With geometry. So the geometry of this machine have a sort of surface that covers the brain in some way that work as a square law. So in combination between a cubic law and square law, we have the linear effect on the magnetic field. It means that with this machine, the magnetic field don't fall like a cubic law, but like a linear law. This is so important, extremely important, because it's the only way to get the target in the middle of the brain with enough magnetic field to have some result.
Basado en esto, hace
According to this, for some years we decided to start research for the transcranial stimulation with diamagnetism. And after many years of research, of very good results, thanks to the help of the engineer Gatta, and thanks to the progress of our patients, thanks to the help of Antonio, Periso, Pietro, and all my research group, today we want to introduce the CTU Euro. So that's our new machine.
So yesterday we heard, it was amazing because what we've seen in the patients is unique. It's been really astonishing. Normally we've seen that in the intracranial stimulations are focused and in the others it is wide, but here we have various things. You have two zones here to stimulate the area on the patient, here relaxing the head, and you can move it, it's not very heavy. We can also use these for the specific areas, temporal, frontal part, so we can do the direct stimulation. But if we have a patient with a frontal epilepsy, then if we don't want to do everything, then we can work with this, being focused and with a radio frequency. Also, we have a software so that we can here watch the brain and see where we want to work. So now it's no longer pain, it is a tremor. So this is the new process that we are working with. We're developing this with a team for neurodegenerative pathology. So thank you so much, dear engineer, because this is a great solution. We've already seen some great results. So I want to thank the whole Pariso team. So we have some volunteer here with a brain problem. Not suggesting that you have it. Do you have anything metallic on your head? Then we'll have to remove that. So basically, so here, so the idea is to have here the whole process of the crane working from behind up to the cervical area. So the union of all the areas, and the cerebellous bridge is also here. But if we want additionally to work on the prefrontal area, this is what is going to happen. So the results will be really interesting. So what do you feel when you do the therapy? Well, you don't think anything, it's just a little bit of noise, but the results are amazing. I already presented this in a meeting that we had with a guy, 20 years old, who had a car accident with a possible brain death. In the encephalogram, it didn't show a total brain death, but well, this guy was in the hospital 1 month. And then when he came to our place, he was just breathing, but nothing else. Gastrotomy and tracheotomy. He was not speaking, no communication to the environment. So it was difficult to have a stem cell. It was difficult to have a stem cell treatment. And it was his kid who answered the phone when I was asking how he was doing. And he said, oh, he's very good. And we could see that he could already have some food and stand up after 1 month. 1 month before, he had been told he was going to die. So this is now the big change that we have, and this is really simple. We have here the depth of the management here. So this is here quite easy, quite simple. So here, this is if we want to work on the cell membrane. And now here we're going to work with the radio frequency. So here this we'll have just in a couple of minutes. And here we can activate this. So this is what happens. Here's the activation. Do you feel anything? Now you can hear it. Listen, what do you feel now? Nothing. Do you hear anything? Yes. What do you hear? Well, I hear clack, 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 clack. So that's the therapy. It will last for 15 to 20 minutes to improve with the patient. So what brain problem did you have? She had no problem. Oh, well, so then she will stand up really good. Well, so thank you so much, everyone. So this is our CT €1. Thank you so much. You feel good? Yeah. Great, so thank you so much. That's amazing, right? Our future. Great, so thank you so much for this prize. So we're gonna move on with our third block of the day, which is pain therapy. We're gonna have Giacomo Besana, Nicolo Francini, and Sara Gatta.
Machine that has been presented today, we are going to present why our research on Parkinson's disease and related to the shaking. So Parkinson's disease is a very complicated disease to explain, so I'm going to reassume it in little words. It's a neurodegenerative condition that comprehends the depletion of neurodopaminergic neurons and based in the basal ganglia, more specifically in the substantia nigra. So our research is based on the understanding of the damage of the basal ganglia in relationship with Parkinson's disease. So we, specifically, we aim to investigate the presence of that predictive model based in the substantia, in the basal ganglia, in the subcortical area of the brain. And our assumption is that human being, for being able to perform fluid and fast movements, must have this cancelling delay system, this predictive model system. In fact, Parkinson's disease is known for its shaking because they are not able to perform these fluid and fast movements like I'm doing right now. So we believe that investigating the presence of this predictive model, we will be able to provide insights into the mechanism underlying the disease of Parkinson. And, sorry, no, è giusto? Is it right? Okay. Yeah. And this will lead us to the development of a new and more efficient and specific treatment for the treatment of the shaking in Parkinson's disease. So the treatment that we know today are mainly two, like the levodopa and also the surgery, but the surgery is very, very invasive and it's not long-term most of the time. So our our goal is to develop this new technology that will be very efficient in the treatment of the Parkinson shaking, and also long-term, and will help to make better the quality of life of Parkinson's disease patients.
Homunculus corticale is essential to understand why the hands start shaking in Parkinson's disease patient. In fact, it points out that the most part of cognitive activity of movements is deputized to the hand. For the same reason, the most part of subcortical zones will be delegated to control nerves connected to the hand. Therefore, if a predictive model fails, the first part to give up will be the hand.
In our research, we focused on analyzing the peripheral nervous system, and then we managed to develop a mathematical model to represent its functioning. To do that, we used two simulative software, MATLAB and Simlink. In particular, we developed an electrical circuit based on the differential equation that governs the functioning of the peripheral nervous system. This approach allowed us to test and verify much quickly and cost efficiently than other research methods. We use MATLAB and Simlink for simulation and verification of our model. Thanks to these analysis tools, we were able to evaluate the behavior of the system in different scenarios and develop a more accurate and reliable coefficient to represent the peripheral nervous system. However, modeling such a large number of RMBA nodes, around 50,000 in a 60 centimeters segment, who would have been computationally expensive. To overcome this problem, we found a coefficient that could more efficiently represent the overall behavior of the system without to need modeling each individual RMBA node. This coefficient has been obtained through the analysis of experimental data and simulation in various scenarios through MATLAB and Simlink. As you can see from the screen, there are two different parts. On the first one, we have a nervous system, which in our case is responsible to transmitting the signal from the brain to the hand, which in the second part, we have a circuit that models the phenomena. Okay, video. It's on video. Click. Sorry. Okay, in particular, we represent the brain as the signal through the transmission line with cascade inductor and capacitor. Then the signal passes through the reflex. Okay, these are transmission line. After we have a reflex arch, and the signal after that passes through the second transmission line, which finally sends to the hand. Go.
So to simply explain what Nicolò and Giacomo are going to explain, about the mathematical model after this, it's really important to understand the concept of the PID controller. So, and why and how sometimes fails to work. So I've prepared a simple example to explain to you. But first I want to say, so a PID controller is something that you can find everywhere. You can find it in the oven of your house and also in the air conditioning that is controlling the temperature of this room. So you don't need a lot of imagination for this example. So there is a photo there. It's made by an AI. And it's not what I wanted, but it's similar. So imagine having this really long oven, closed oven. You can't see all the pizzas inside. So it's 1,000 meters long oven, pizza oven, full of pizzas. So it's really full from the start to the end. So you have a man at the start of the oven and another man at the other end of the oven. The first man that put the pizzas in has a knob to control the temperature. And the man at the end tells the first man if the pizzas are cooked, raw, or burnt. So the first pizzas come out. Always remember, this oven is 1,000 meters long and full of pizza. I'm going to repeat pizzas a lot of times in this example. So the first pizzas come out, and it's raw. So the man at the end tells that the man at the start to increase the temperature, so the temperature is increased. And it happens again, the second pizza is raw, and the temperature is increased again. But at one time, after increasing the temperature so many times, every time you see a raw pizza, you start to see only burnt pizzas, because remember, the oven is full of pizzas. So if you continue to increase the temperature, the pizzas in the oven that are at the start will get burned. In fact, when you see burnt pizzas, you try to decrease the temperature and decrease it, but it won't work, because after that you will see only raw pizzas. So this system is called error amplification system, and there is a problem. The problem is the delay of the feedback. So the feedback comes too late. In fact, you can decide the temperature of the oven only by seeing if the pizzas at the end of the oven are raw, cooked, or burnt, because it's too little information. So you can see the equation there, and so the PID has three main parts: the proportional, integral, and derivative part. The proportional part has to create an output that is proportional to the error. So if the error continue to increase, you will have to know how much strong has to be the response of the system. Then the integral part just correct the error of the steady state. And then we have the derivative part that is correct the error if it depends on the speed of the error, and it corrects it. In fact, you can see that it's multiplied by a k coefficient, also called derivative coefficient. And yes, this is the PID controller or error amplification system that you will hear a lot during their part.
In the making of the model of the patient affected by Parkinson, we decide to utilize the PID controller to help regulate the negative feedback signal. This type of controller is made of three main parts: integral parts, proportional parts, and derivative parts. Once the PID controller receives the output signal, which in proposed example, cook raw on burnt pizza, is able to make a decision based on the mistakes, which could be seen as a percentage of difference between the cooked pizza and the one that will be taken out of the oven. Basically, the PID controller takes this error value and utilizes to regulate the temperature of the oven. So that's the ideal temperature to cook the pizza can be maintained. The proportional part of the PID controller regulates the output of the system in a way that is proportional to error. Increase or decrease the temperature of the oven based on the error direction to bring to having the same auto-oscillation that in the patient affected by Parkinson manifests with the shaking.
Okay, so the problem exposed by Sarah as a solution. In fact, to increase by far the number of well-cooked pizzas, you need to know the mathematical model. And so we are able to identify more variables that describe the phenomena. In our pizza example, can be air temperature or humidity of tomatoes. Thanks to this knowledge, we were able to predict the outcome of cooking process even before inputting the signal, in our case, the pizzas. This solution can be represented by a Kalman controller. In fact, we took more variables and we made some operation on this. In fact, first of all, we made a pre-processing of the signal. That means that we measure the error at constant times. And after that, we multiplied, derivated, and integrated for an optimization coefficient, which allows us to create a new input signal. This new input signal will allow us to the ideal result. To understand those graphics, we have to imagine asking at two different people, one affected by Parkinson's disease, the other without Parkinson's disease, to indicate an object. To simulate that scenario, we used a PID signal represented by the first graph and a Kalman signal represented in the second graph. We expect that a patient with Parkinson's disease will take more time to target an object as compared to a patient without Parkinson's disease. And looking at the results, we verify that our mathematical models are correct because the stabilization time of a patient without Parkinson's disease, so with PID, is 3 times that of a Kalman.
So now we're going to present a little bit about the technology that we thought about. So this is a little summary of what I've said before. So now the treatment that we have are the surgery, the levodopa, and then there is the technology that we thought about. And the goal is that it doesn't have to be invasive as such as the surgery, and has to be the more efficient as possible, and has to treat Parkinson's symptoms, specifically the shaking, has to have a long-term relief of these symptoms, and has to be also like durable.
Okay, so as Sarah said, we can turn this technology into a product. We imagine a system with 2 electrodes, the white ones, and a machinery in the middle. The purpose is to bypass the delay produced by the nervous system. To do this, we need to inform in advance the brain that the end position is changed, and we can do this with an electromagnetic reader. The other electrode could be an electromagnetic stimulator that carries the electromagnetic data to the brain as feedback. Electronics allows us to do this extremely faster than nerves. In fact, we can bypass the delay produced by the nervous system thanks to electronics.
So for last, we wanted to thank the ECM Folk Foundation, the Polytechnic of Tirana, and also RIA, that is a neurology that helped us with the most medical aspects of this research. Thank you.
Muchas gracias, Giacomo, Nicolo, Sara. Muchas gracias por vuestra presencia y vuestra intervención. Bien, la siguiente ponencia tiene un título bien sencillo. Bien sencillo. Experiencia en un centro de terapia del dolor. Anteriormente ya participa como líder de una mesa de debate, en esta ocasión lo va a hacer como ponente. Un aplauso, por favor, para Luca Gallelli.
Pomeriggio.
Good afternoon. I wanted to congratulate these guys because it's very important to have young people working for innovation. And also because now we are organizing the National Award of Innovation in Italy. So having young people that have these ideas, that's very important. I'm going to talk very quickly about our experience. I won't talk in detail because thanks to the organizers, we could have the young people that brought the clinical experience in the pain therapy. So let's talk about an center managing pain therapy. That's very important. We're a pharmacological group, clinical toxicology group. So pain therapy is limited to neurological aspects, among others. in a world in which a network works with an organization, sometimes you work by yourself. Sometimes there are other people who run these studies. And we wanted to do something different. A few years ago, thanks to our professor, we started a journey. It was not only about the project. We had one idea. We didn't want to consider a profession, but considering a group of people that work together in an organized way, and they work in a project. So that's why we wanted to take a step back and we wondered, what's the need? We wanted to focus on the patient needs. The patient needs is not pain therapy, but treatment. So that's why we wanted to go back to the initial territory. So we created what you are seeing on the screen. That's a pain management center, pain therapy center, that brought the university, hospital, and territory all together. And we had the chance to work with many different people from different fields. Because the physician role is a team's role, but it's true that we need to have one leader to lead the team. So we wanted to bring everyone together, and we know that all of them have their own skills. So if we get all of them using their own skills for a final purpose, we will win. Those working with pain therapy know that pretty well. Pain might remain. But we don't want pain to be over. We want to improve patients' life quality, because that's how patients will live better. We were just a few at the beginning, but the team has growth. And we think that without scientific societies, we cannot make it to anywhere. Scientific societies represent what normality should be. They represent a journey that should lead to the visibility of daily work. So that's why this is quite old, because when we were preparing this presentation, they asked for it in advance. So after that, two other hospitals joined, but we didn't modify the presentation. Well, anyways, when all this was created, the main idea was to bring everything that was necessary together. The global care patients, for patients, innovation, research. You will listen to what's the first patient assessment. That's the normal assessment. Of course, we know the drugs, but no drugs work if we don't start with a diagnosis. If the diagnosis is the correct one, we can meet our goals. But if the diagnosis is not the correct one, we cannot even start. Pain changes. Pain keeps changing. It's modified. We have chronic pain, severe pain. There are many different types of pain. Things keep changing. And pain's definition has also changed. Of course, it's according to everyone's opinion, but there is some objectivity in that definition. There are some pains that keep changing because we are becoming aware of what pain is. And we know that patients require attention, require care. So we need to make different categories for pain. Otherwise, we cannot develop different treatments. So first, we need to assess generally the patients, until we can divide pain into different categories. We always say that we need to measure pain. But what has changed in this definition? One data has changed in this definition. For a very long time, we used to measure pain, and we just asked, what's the level of pain that you have? 10, 0, 1. That's just a number. But if it was a value and I can put it together with that number, that's very important. It's very important, especially when you can follow your patient's journey. But when does the pain vision change? When we don't give a number to the evaluation of a status, of a condition. For a very long time, when patients would have a level of 9, we would give them hallucinogens. Opioids, and it depended on the pain level of patients. But now, pain management has changed a lot, so that's why we need to do some follow-up on those patients, and that's why we started a journey, because there are some assessment scales, for example, the F36 to measure life quality, but the idea is the same one. We want to integrate all the different competencies in order to get a personalized treatment and therapy. Of course we can do it. We used to have a starting point. We knew the drugs, but we thought that with the drugs we could reach everything. But Pietro Romeo came in and he said, okay, there is something new. And he knew some engineers, and they had a machine in Catanzaro at the university to assess how this machine could have an impact in drugs. And I said to him, okay, let's see what happens. So from July 2021, June 2021, we brought this instrument, and it was a revolution for us. Was it like a cultural revolution? You might wonder. But why? You might wonder. Imagine that it's like some molecules moving, and all of a sudden they can see a receptor, a machine like that. So some pharmacologists say, we can start using something that's not a drug. And I would say to you that technically, this machine can be a drug as well, because this machine can modulate different things, and it can have a therapeutic effect. So as you have heard, it's an effect similar to the drug's effect. It has a duration and expectation. So that's why we really liked this mechanism. And that's what we saw. We understood that the equipment could do many different things. I won't explain all of them because you will see what we can do. But it's interesting that we try to customize everything with a starting point. That is patients, and we consider weight, the body mass, the fat, the age, and of course the gender. Gender is important. We're not talking about sex. So in 1 week, there will be the European Congress on Gender, and that's very important. Gender is not about women or men, and that's an opportunity for us. So this allows to treat many different things, this mechanism, and that's how we could grow by achieving innovation, by achieving the future. We can treat the disease, but the question here is, are we treating patients? Because we have many problems when it comes to treatment. And when it comes to the drug treatments. Today we're talking about pain. 15 million Italians. We're over 60 million Italians. I'm talking about between 20–30% of the Italian population suffers from pain. So nowadays, with these machines, and of course the IT medicine, that's very important. And of course, we should not forget AI and remote medicine, because they will open the doors of the world. This is just my opinion, and we should consider many other things. It's a journey that we started, and it's not very difficult, because at the end of the day, it's important to believe in all these things. We need to understand that we can do many different activities, that we can treat many patients. So we started a training journey, because we are also a university. Pietro Romeo and other people who are here in the room, they are lecturers, because we started with a master in pain medicine. And that's for this year. That's not called anymore pain therapy. That's called pain medicine. That's totally different. Of course, we tackle therapies, but medicine means that we are responsible for our patients and that we help them. That's what we do every day. We have patients with muscle pain. We have patients with ulcers. And they thought that those treatments were not going to be efficient. And we understand something that's very important, that we can work in teams by conducting several clinical studies and by focusing on different parts. But we should never forget patients. They are the most important part. And in the future, of course, we will use AI. But what we have understood so far is that we can work if we work all together. Thank you very much. Okay, thank you very much, Luca, Gallelli. It's been very interesting. And next conference will be as interesting, which is pain identification and actual concepts. Lucia Maraca, welcome. A round of applause for her.
Good afternoon, everyone. First of all, thank you. I want to thank Paradiso Academy for their invitation to be here. It's a great pleasure to share this conference with you. So when we talk about pain, we need to start by defining what pain is. So those who have been working in this field for many years, like me, we know that for the first time after 20 years, because, well, the first definition was in 1979, but the ISP changed the definition of pain, and it started to be described as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Why did we change the definition of pain? Well, that's because we realized that in the previous definition we were missing something, because in the definition in 1979, pain was described as something that could be expressed verbally or orally, but there we were eliminating, for example, elderly patients with cognitive problems who cannot express their pain, or even the newborns who cannot express their pain orally. So the International Association for the Research of Pain published this, and this was very necessary because we realized that pain is an experience, it is a subjective experience, where we have the perception of the pain, but also the memories of the experiences. So here, this is the International Association for the Study of Pain also says that there is a primary and a secondary pain. The primary pain is related to what we define as dysfunctional, like fibromyalgia. And also we have a secondary pain, where we can have a pathogen that has changed the nociception, and here we also see the neuropathic pain. So nociceptive pain is related to tissue damage, and in the neuropathic pain we see that the fiber of the neurons do not generate the impulse. So this would be applied to neuropathic pain. But in the case of nociplastic pain, this is something difficult to treat because there is no proof that there is a tissue damage or multisensorial damage, but patients tell us the background of their pain. So we had the identification of chronic primary pain, which is due to the alteration of the normal rules. When we have a patient with a pain, at university we were used to thinking of the disease underlying the pain, but some patients need to have immediate responses no matter the disease or pathology underlying that pain. So how can we identify what type of pain they have? How can we distinguish nociplastic and neuropathic pain? So if we think of a journey of our impulse, here, for example, we can see that there is a hypersensibilization here of the peripheric receivers. So here we can have a reduction of the threshold, the nociceptive threshold, and with the synapses, there's so many things. For example, we can have an amplification, an increase of the impulse, or this impulse will get to the very top, and only in cortical it would become pain. So everything underneath the parametrics here affecting different areas, like for example amygdala. There we can see various impulses, and it is there that it becomes pain. So everything before is a nociception. We can have nociception, but we can have no pain without nociception. So we have an impulse traveling through the delta fibers responsible for the fast pain, for the quick pain. And also we have the myelinized fibers responsible for the secondary pain. This is a bit slower. And then we have the beta fibers responsible for the tactile reactivity. So what do we do if we have a patient with pain? We need to find the pain generator this is where the pain is produced and the mechanism underlying this pain. And not just the disease causing this. So this is the peripheric nociceptor and the sensitivity. So normally this is a system with a high threshold. So we need here a strong stimulus. And when we have some phenomena like cytokines, where the threshold goes down, then we have a hypersensitivity of the nociceptor. And this is why we have the nociceptor inflammatory pain. And if there is a lesion of a fiber causing pain, like a neuropathic pain, like diabetes neuropathy or chemotherapy, that causes peripheric pain, there we would have a neuropathic pain. Or in the posterior horns of the spinal cord, we have an impulse that can be modulated. We can inhibit this or amplify this. So in the case of the amplification, or what we call secondary allodynia, there we can have an alignment of various impulses. So the patient can no longer distinguish where the impulse comes from, because everything turns into pain for the patient. And I'll show you how we can find this secondary allodynia, which is a symptom of an additional sensitivity of the spinal cord. As we have the sensitivity in the brain, in the central area, and here we still need to do a lot of research in order to better understand what happens with sensitivity in the central part. So probably this is also related to the central sensitivity. So if we have a neuropathic pain and the necessary and the inflammatory pain and the central inflammation, as Professor Gallelli explained, the assessment of a patient with pain is very complex. We need to think of not just of the patient, but also of the complexity of the patient. If we think of an elderly patient with a polytherapy and other diseases, we need to take all this into account. So we need to use various tools to confirm a hypothesis of diagnosis. So we need to examine our patients again, because the research with our tools only helps us to confirm something that we already know. So how do we do this? We do this through consultation with the typology in general medicine. This is a 5 minutes medical consultation, and during this visit we need to identify the area of pain. Also, we need to identify the pain of the highest pain area that is probably linked to the pain generator, then find the secondary line, the secondary allodyne. So we need to have the patient explaining the path or the route of the pain and then draw it on their body, because this will allow us to draw or understand what pain are we talking about. And also we need to ask what the pain with the highest pain point is for the primary allodyne. So we ask the patient where they feel the strongest pain, and after them telling us, then we draw it here with a red pen. We mark it here with a red marker, And probably we'll have here our pain generator. And after that, we're gonna assess the integrity of the somatosensorial system, identifying all the beta fibers. I'm going to ask the patient if they feel the same in the different areas. So we're going to do this. And we'll be pointing this with the different tools. And the last tool will be here the assay or trial pipe filled with hot water, and we'll signalize it the same. So we'll see if the mechanisms are positive, to see if it's all the three are positive. This is a neuropathic pain, and if it is negative, then it is an inflammatory pain. So it's a nociceptive pain. So now we need to assess the secondary allodyne. So we'll ask them if the marker is causing some pain. Some patients will suffer a lot if they have a secondary allodyne. So we can also ask them if it is difficult for them to wear some clothes or leggings or putting their bed sheets on their body. So this is secondary allodyne. So next we're going to have Dr. Boca, who will show how this first assessment phase will help us to conduct and to implement the protocol of Diamagnetic protocol in each case. Thank you so much. Thank you so much, Lucia Muraka. So we're coming to an end of our third block. So please get ready, all our speakers from this block, so that after the very last speaker, you can come up to the stage for the Q&A session. So this is our next paper of the day, Cristina Boca. So please, a big round of applause.
Buon pomeriggio a tutti.
Good afternoon. Thank you very much for inviting me here. As we could see in the presentation from Muraka, pain is a very common clinical condition. From the point of view, from the social, economic point of view, that's something that's very important. So we've been doing some research. We've conducted some studies in order to develop a therapy that's efficient, but that's long-lasting as well. So the diamagnetic therapy is becoming more and more interesting, especially with the force points. So we start with the application of a magnetic field in low frequency. So we've done some studies that compare high and low frequency, and with these parameters we can obtain what we are looking for. That's efficiency and duration, and it is a non-invasive therapy. So we will be talking about patients that are doing therapy and they are not worried at all. It's a very simple and easy therapy, and we can treat different types of pathologies such as low back pain, ulcers. It doesn't require a lot of time, just 20-25 minutes. And in those 20-25 minutes, we don't only do physical therapy. We also treat one part of pain that's very important to me. As we have seen before, pain has an emotional and a physical part, especially when it comes to the chronic pain. The emotional part is very important, because the pain internally, when we assume pain, that's very important. And we saw that usually patients require psychological support so that they can have more benefits in the physical part. So in those 25 minutes, we achieved to do a physical and psychological treatment at 360 degrees. But why does the diamagnetic therapy work in pain? Well, it is because it's not only based on symptoms resolution, but it has an effect at a biological level. As it modifies the mechanisms of cells, it empowers all those mechanisms that the cell already has and that the pathology ruined. So we could say that it provides balance to a tissue that doesn't have a balance anymore, and we can see that in different tissues. For example, let's talk about neurons. The neuron is the main actor of pain, and the diamagnetic therapy has a neuroprotection effect, especially when it comes to the anti-inflammatory effect and the capacity to provide stimulus to those factors that lead to brain death. So we have a lot of mechanisms that work to protect a very important cell, and then we need to talk about neuromodulation with the protection of the magnetic field. So we can protect the capacity of the neuron, and we can act in the different channels such as sodium, calcium, and potassium, and not only at a peripheral level, but also with a very fine mechanism at the transcription level. In a tissue with pain, transcription is a cause. The expression of the receptors is chaotic as well, so we try to bring balance. So we try to solve that cause. And it's a mechanism that we use in the tissue generation. That's a capacity that we think it's very important. And we can assess that in the different tissues we deal with very often. In the joint tissue, one of the most common pathologies is OA. It has a very strong inflammation, and those cells that should protect those cells become damaging cells, and they worsen the inflammation, or at the level of the intervertebral disc. Thanks to the diamagnetic therapy, we can fulfill the objectives, and the mechanism is finer here. The magnetic fields can create some shakings that are surrounding the cell membrane, and they can create some order. So this way we have a normalization of the calcium channel, a normalization of the relationship of potassium, among other things. We also have a normalization of communication between cells. So we should go back to the homeostasis of the tissue. So tissues get all these mechanisms that allow them to contrast the different things. So we can get all those mechanisms that work to preserve the intervertebral disc. There is another capacity, which is the resolution of the edema. Of course, we make the most of the repulsive capacity of the magnetic fields. So in this case, we put the edema liquid from an area away so that it works better. And then we have another characteristic which is also very interesting, which is the effect on neoadhesion angiogenesis. That's a mechanism that might be positive or negative, according to the tissue that we have. It might be negative in the case of OA, so if it's pathologic. And this tissue in an inflammatory environment, it's a tissue that causes inflammation. So this worsens the clinical record. But could you imagine another relationship in which the relationship with oxygen is totally different? We could modulate the expression of the factor GF to go back to a balance of tissues. And then we also have anti-inflammatory effects. But all these characteristics we worked with them on the crown. We used that therapy as an anti-inflammatory therapy, anti-edema analgesic therapy, in order to increase the viability of topical compounds without using caps or invasive methods. Or we used that as well as an alternative to the diamagnetic therapy with patients that do not want to use it. So I brought 3 cases. So that's a patient. And she had spondyloarthrosis. She has a chronic pain. She's been under treatment with paracetamol, no results at all. And she was under treatment with other drugs that caused side effects with a very strong pain. We are talking about a pain of 8 level according to the NRS scale. So we used the diamagnetic therapy with another relaxation method. So the treatment took 25 minutes. And we repeated that 10 times. We achieved RS1. So it was just something annoying. It was not intense pain anymore. And we realized that the life quality improved and there were not side effects. There is another case of a woman with algodystrophy. In this case, she had a chronic pain and a pain of level 10. That's the strongest level of pain. And that came after a trauma. So the woman had done different pharmacological therapies and treatments, and all the drugs that we have now for algodystrophy. But those drugs didn't work, or she had some allergies. So of course this woman was scared to the pharmacological therapy. So we decided to have protocol algodystrophy 25 minutes, and we reached a pain level 2 after 10 times of diamagnetic therapy. So the edema was of 3 centimeters, and then there was no edema, and she improved her life quality, because we are talking about a woman who went back to doing all her activities that she couldn't do before without side effects. Last case, a patient with cervicobrachialgia. So that's a man of 50 years old. So we decided to use diamagnetic therapy with pregabalin, cyclobenzaprine, so protocol 37. And here we did between 10 and 13 therapies. And we could cancel pain without side effects. So what we could see, thanks to our practice, is that the diamagnetic therapy is a very efficient method that gives benefits last over time. We can use it in many different pathologies, and it's very versatile. So we are hopeful that we can apply that in the future for many more pathologies. Thank you very much. Thank you very much, Cristina Volka, for your conference. Please don't leave, because we are going to start the debate table, all the speakers that took part in the third block. So I wanted to thank all the participants, because you were very precise and accurate with time. You know, it looks like Swiss technology. So, okay, I'm going to call all the participants: Giacomo Vesana, Nicolo Francini, Sara Lacata, Luca Gallelli, Lucia Muraca, Cristina Volka, and the leader of the table will be Giovambattista De Sarro and Rita Citraro. Thank you very much.
Por favor, vamos sentándonos en las butacas. Quizás podemos traer...
Please be seated. Maybe we need more chairs now.
¿Alguna silla, por favor? Sí. Al menos 2 sillas, por favor.
We are waiting for some chairs.
Dibattito di questa sessione.
Muchas gracias.
Grazie, grazie.
Ponemos por aquí, por aquí.
Allora, ci sono domande dal pubblico, altrimenti... Ha ragione il professore Gallelli, non si vede nulla da qui. Ecco qui, prego.
Already know why Parkinson's people are not able to grip their objects properly. So why do we need to have a mathematical model? What we need to know is how that disease is occurring. So we know the interaction with L-DOPA and so on. Why do we have to have a model for that?
Model is the way to, because typically there is some, for example, with the way that we explain why, from medical perspective, I mean, so the typical chemical approach regarding to the frequency, you are not able to explain why the frequency is exactly 2 to 6 Hertz. And you cannot predict exactly which is the shaking frequencies. And in addition, it's almost impossible to understand why from time in time domain, I mean, in the evolution, because it's not exactly in a sinusoidal signal, it's something more complex. The mathematical model is the way to see the same problem from a different perspective, totally different perspective. So, please go ahead.
Well taken, but still, I think we need a model for another aspect in Parkinson's, because we know that the effect of dopamine, we know that there's neurodegeneration, but we do not know how that happens. So for this, we need a model, but maybe you can implement this later.
So the idea is typically the speed of, so the conductive speed into the nerves and spine cord is too slow. So it's physically impossible to have some smooth movement without some advanced mathematical model. Typically, imagine that you want to control, so like the example that the guy showed on the screen. So the speed of the signal into the nerves is more or less equivalent to the time delay that we have into the oven. So, but we know that from a mathematical perspective, it's possible to overcome this unsolvable problem with a predictive model. If we know, if you put a mathematical model into the subcortical area, imagine, that included spine cord, reflex arc, and and also the muscle, for example, we can, so the ganglia of basal ganglia and also all subcortical, or most of the subcortical area can overcome the problem and can solve the problem. So this is just an hypothesis. Obviously, we have not the final demonstration. We need to have to do many other tests and many other things. But the idea is we can see from mathematical perspective that without this so advanced predictive model, the simulation tell exactly which is the shaking speed of the hands of the Parkinson patients. But if you include into the mathematical model this advanced predictive model, it stops to shaking, and seeing the results of the simulation model, we see exactly the performance that we have with our hands. So the hypothesis is the Parkinson disease will destroy or will reduce the performance of this advanced predictive model. So that's the hypothesis that we are going to confirm, or we want to confirm.
Grazie. Ci sono altre?
Thank you. Are there any other questions? Okay, go. I would like to ask about the difference in order to prevent Parkinson, Alzheimer. What's the difference with a person that's undergoing Parkinson, Alzheimer in a very advanced level?
The only thing that is in hypothesis, this is just an hypothesis. We have not technology, we have not yet anything that works in that way. No? But the only thing that theoretically, this, if the hypothesis is confirmed, we can do is to reduce the shaking effect of the Parkinson. But we'll open many other different ways, because if it's confirmed that we have a predictive model in the subcortical area, we can invent many other technology that can reduce the side effect of the Parkinson disease, and also some molecular that we use for treating the Parkinson disease. So we have just an hypothesis. We are going to understand if it's correct that this advanced predictive model exists, and in case if exists, we can invent something, including the diamagnetic therapy. Because if the model is correct, if really we have this advanced predictive Kalman filter technology, we can use the diamagnetic therapy for reduce the effect of the Parkinson. So.
Qualcun altro?
Any other questions? Felipe? So I would like to talk about Parkinson and then about pain. So what we've seen with the MRI scan is a control of nucleus, but patient would improve their stiffness, but not the shakes. So the idea of the future is that we can use both technologies in order to control the shakes and degeneration, or should we use both technologies by itself?
If we can just reduce the effect of the shaking effect, or if we can.
Is it possible in the future the union, the new device and the diamagnetic therapy is possibility using in the same time, or is a specific different treatment for the patient? For normally is good evolution in the nuclear neurons to stimulation the diamagnetic. For I don't know, is the change fields is possibility blow one or the other fields, or is possible treatment in
No, I think it's possible to do in parallel, but in any case, the device that we are going to imagine is something that reduces the shaking just wearing 2 coils back in your back. So you just read the signal directly from the electromyography or directly from spine cord. We use the speed of the electronics in order to bring this signal that normally is carried by the spine cord at a very slow speed with a very fast speed as a feedback for the brain in a way that the brain can, solve the problem of the smoothing of the movement using the very low quality feedback like the PID that we described into the presentation.
Perfect. And the second for the pain is the one theory, the memory pain. Example, in the patient with the dementia, is classic, the pain, the patient refer, is it the pain? I continue the pain. Is really no pain, and the problem is in the cortical memory. You think is possible, wherever treatment include the diamagnetic therapy, outside the idea, the memory, the pain for the control in this patient, and I think not only in dementia is the typical patient, chronic pain is, I question, is you continued pain? Yes, all time. I continue for no pain, the other articulation is only here for continue the problem with pain. Are you, is thing good?
Yeah, I think that's a problem regarding pain. So we have a problem with pain. There is the pain memory, it exists. And it's related to the amygdala. And we always make some questions about it. That's related to tonsils. And it's very important to talk about it and consider that. We know that exists, that's formed, and that's given by memory. But in a catastrophic sense, if there is a diagnosis that's not codified anywhere, nobody knows what's the healing time gonna be. But after seeing many patients with fibromyalgias or with other chronic problems, we realize and then we'll go back to normal. That's something we've seen constantly. Children running, children falling down, children crying. And like all of a sudden when children are hurt, the mothers kiss them. And all of a sudden the pain is over. And you may think that's not related, but it is related because everything is there. So for example, if we could modulate that small factor, then we will be able to do something. We tried. We know the drugs. We've tried with different drugs. We couldn't, but we've tried. We've tried with psychodrugs, and we just managed a little bit. So I would like to ask Felipe, do you think that when it comes to raising awareness around central sensitivity, for example, this low back pain, by which we provide some drugs, such as opiates, there is a receiver mechanism that we are not going to define because of a lack of time, but the essential part here is what you said before. If we modulate the channels, you said something that was very important in this morning presentation. The diamagnetic therapy can act at the receiver level. So when those receivers are hypoactivated, when the transmitter are moving, they are doing many different things. So in that case, if we modulate, as Christina would say, if we order that cause, maybe we don't know how we can deal with that non-sympathetic pain. So possibly this will represent a hope for the future of our patients. Okay, any other questions? Okay. Okay, I don't think there are more questions. Okay, I think we ran out of time. I know it was a joke. I wanted to ask Christina. So Christina was talking about some cases in which the diamagnetic therapy worked in our clinical centers, but maybe there are some other cases that you didn't talk about. But we know that often patients come with a lot of drugs. So how important is the diamagnetic therapy in those cases? For example, patients are used to pain, so that's why they're having a lot of drugs, a lot of medication. So yeah, if we reduce pain, all the drugs that are used for pain will reduce. For example, nowadays we use a lot of anti-inflammatories that lead to many different problems, to many different interactions. So that's how we can manage pain. And if we can manage pain, and if we can do one physical methodology, we will only have benefits. Maybe you've been working with it as well, right? Okay, Professor Gallelli, I have another question, even though I answered before. So the diamagnetic therapy, you were talking about the difference between gender, about also the Muraka was talking about the difference of gender. So according to your experience, as for the response towards the diamagnetic therapy, was there anything different between women and men? In our case, there were not many differences between males and females or gender. We don't talk about gender, not in the biological sense, but in the non-biological sense. So what do I mean by that? Is that we usually offer health services for free. So regarding the economic part, the religious part, that's not compromised. And I gotta say that that's the real obstacle. From the biological point of view, we could see that the difference between women and men, actually we didn't see a huge difference regarding the response. And this is due to different factors. For example, we study gender in all its different ways, but we could observe that there is a possibility of modulating treatment to change frequency, intensity. We can change that according to the patient's framework. That's also related to sex, weight, gender. Okay, we ran out of time. Thank you very much. And we will see each other very soon. Okay, how are you feeling? Are you having fun? I hope you're asking all the questions. This is a debate table so that all of you can ask all the questions that you want. You have a mic in your chair and you can solve your questions. So now we are going to change the register and we are going to move on to a new block on clinical cases with the CT MIGA20, CTU S-Wave, and Neuro. I'm very happy to introduce my friends. He's Juanma Morales. He's an expert in CTU MIGA20. So please, a round of applause and welcome Juanma Morales. Hi, good afternoon, everyone. First, thank you very much to Fisao de Ampariso for giving me the opportunity, and congratulations to all the speakers, because the conferences were very interesting and very enriching. Since 2020, since the pandemic, I've been working with the pump. It gave very good results. We bought it in a very complicated moment because they brought it in February 2020. Of course, then we are in lockdown. So I have the lockdown, the investment, and my wife telling me things all the time. So it was like a chaos. But we had the opportunity in those pandemic moments to conduct several cases. For example, there was like a broken tendon, a traumatic hand. To work all over that time, we had like 4 patients, and we had very good results. They were amazing, and today that's the day I can say to my wife, yeah, can you see, I was right. So it went very well. So what I'm going to do is I'm going to present a clinical case. That's something different I've been doing. That's something I prepared for the conference, and that's a hip arthritis. And that's so that you can see the capacity that the pump has. There are some techniques, some technologies, because you know I'm a physiotherapist and we are in love with technology. We spend a lot of money on those machines and they work properly. So you say, okay, you buy that and it works pretty well. And when you get the diamagnetic pump, you are excited. And it's not because I'm just saying good things about it, but I'm telling you, it actually worked. So I'm going to present the case. So this is a case of hip arthritis. So the patient is a patient of 49 years old. So he comes to our consultation. He could barely walk. He could barely move, and he could barely sleep. And he would get worse over the seasons, and he could not do like the daily activities. So it's a patient that would suffer from hip arthritis at a severe level, like he would have spent 1 month like that. He was working at an office. He does not have overweight. He's active in sports terms. And he doesn't have any rheumatic diseases, but it's true that from time to time, especially like in the past 3-4 years, he would have some of these episodes. He has arthrosis in both knees, and he was treated with PRP, and he got very good results in those knees. So after discarding some red flags, we started the exploration. We could see that when he was walking, it was very painful for him. When it comes to internal rotation and flexion, he could barely do it, you know, and he had like the typical type of walking as a person with hip arthritis would have. And then we have the father resisted SLR, and all of them were positive. So when he would move, that was very painful. And here I agree with other conferences. Like, for example, if we have one diagnosis when we are conducting an exploration, a proper one, and if we have an accurate diagnosis or the most accurate diagnosis, the treatment is going to be specific for each patient. So the first thing that we don't have to waste is our time. But we have to waste our time in this exploration, not in anything else, to know what patients are, to see what patients have in order to provide them with the best treatment. So 2 questions that we usually ask, and I really like them. So we ask patients, what do you think about it? And he said that he would have something inflamed, and his objective was to reduce and get rid of pain. He wanted to eliminate pain. He was not talking about the function, and that's something we like to value. We like to assess the function. We want to assess the function's improvement. So the first hypothesis was the one of the arthritis of hip. So he comes on a Friday, and in the first session we have some objectives. We wanted to reduce pain, as he said, and we want to have more movement. And that's the first objective for us. So he would have an EVA of 5 and 6 on 10, because every time he would start doing something, he would start with pain. And we did a treatment with the diamagnetic pump. So we started with a 10 minutes liquid draining. So 10 minutes for moving fluids in order to drain that inflammation. 5 minutes of molecular implementation. Thank God that we have a doctor in the clinic. And regarding the molecular implementation, we really like it with the pump because we can find very good results. We mix it with a cream. We add another drug in order to eliminate that pain, so that step by step we can mobilize the patient with a better response. So after that, we started with 5 minutes of neurological treatment in quick fiber. That's the beta fiber. That's how we can get the most sensitive pain. And then we would give him 10 minutes of joint tissue in order to stimulate the joint part of the hip. And of course, we are always combining them with hand therapies. I don't like using just one single technologies. We use different technologies, mobilizations. We really like the work of the pump, but we want some movements, hip motions, hip movement, as we keep implementing the pump work, and that's how we are getting the best results. So this is an ultrasound image from the arthritis, from the hip arthritis, from the patient. So if we can measure that, that's data that we can have in order to analyze pre and post. So I said it before, he had an EVA of 5 to 6 after the first session of the pump. And that's how, if you understand about ultrasound, so that's the joint. That's the intrafemoral joint, and underneath there is the arthritis that the patient would present. And that's what we use in order to objectivize the function. And we could see that in the healthy leg, that it was the left leg, he had like 264 minutes of strength on the hip, while in the left leg it was like 100. So that was the before and after. So you can see the similar things regarding the left and right hip. It was 264 in favor for the left hip. So we did this session number 2 on Monday. So in severe pathology, we don't use the pump every day because it can create a very small anti-inflammatory effect. And if we prove that if you use it every day, it doesn't have very good effects. It might even react. So we just leave 2 or 3 days between one session and another session. So in this second session that happened on Monday, the objectives were the same. We wanted to reduce pain. We wanted to have a better range of motion. He had an EVA of 3 in 10. And the treatment was of 15 minutes of fluid motion. Then we have molecular implementation for 5 minutes and 10 minutes of joint tissue, and also, of course, mobilizations and manipulations. That's for manual therapy. And we would also do some neuromodulation. That's an invasive therapy on the nerves, so that we could reduce pain even more. In the third session that happened on the Wednesday, we left like 2 days in the middle. We wanted to improve and control movement. We wanted the movement control to be the proper one. So regarding EVA, it was 3 in 10, and he left with over 2 or 3 in 10. So the treatment changed: 10 minutes for liquids, for fluids, and then 10 minutes for tissues. And regarding neuromodulation, we went from 3 to 2 in order to improve the situation. So in the third session, that was the ultrasound picture from the patient. So we can see that there is a very important improvement. And regarding strength in this third session, he has improved. He was like 100 newtons and now he's 175. And in the fourth session that happened on a Friday, he came with a pre-width of 2/3/10. So the pump treatment was very similar, it was the same. And regarding the manual therapy, we changed and we started doing some exercise such as wall sit, climb, bridge. And we wanted to improve everything. So that's why we would do frequency sweeps. And on the fifth sessions, we wanted to provide him with strength because everything else was very good. So we were working on strength. So Eva was 2 in 10 and he left with 0.5 wound in 10. So of course it was not a very intense pain. So the diamagnetic pump was same one, 10 minutes for liquids, for fluids. And yeah, we also did the frequency sweeps. So that's the last picture. Though he barely had symptoms, the inflammation, as you can see, there is no inflammation at all. And that's the last picture regarding the assessment. And you can see that left 266 and right 249 with a 6.5 of asymmetries. And you can see the differences between the different sessions and improvement in the last session. And not only regarding pain, but also regarding functions. So that's the average, that's the asymmetry, how we started with 62.1, and now it was 6.5 between the left and the right hip. So if we consider that from 10 inwards, that's pathological, I think we could say that we are in a very good process. He didn't say that he had done it quicker before. So we measured everything and that's everything. So thank you very much. Okay, thank you very much. Thank you very much, Juanma Morales. It's always a pleasure to be with you. You've been very kind. And it's been very kind to come here to share your experience with us. And next speaker is going to be as kind as Juanma, and he's going to talk about his clinical cases. He's called Gianmarco Tacchiano.
Good afternoon, everyone. First of all, I want to thank Paris and Pietro Romeo for their kind invitation to be here and to tell you about diamagnetic therapy in prostate gland for children. So it's not a tremor, but an increase of the volume of the prostate that creates blocking in urinary terms. This pathology is more frequent after the 50 years of age. So what can we find here for the treatments? We have various options. We have behavioral treatment, like for example, not going on a motorbike and avoiding certain food and things related also to the sex life. But also we can see some drugs, like alpha-lytic drugs or in 5-alpha reductase inhibitors. These work quite good. But what's the problem here? Well, they have some secondary effects. So, for example, this leads to a reduction of libido, and this can be a relevant problem. So what do we do in those cases? There is a surgery on the patient, and this could also lead to some problems. So the goal of a study was to analyze And we've seen some improvements in a group of 15 people. And the treatment would last for some weeks. Here we have some criteria for inclusion and exclusion. So we were very strict. We spoke to a urologist, and our patients had a follow-up with a urologist who would decide whether they should be examined tomorrow or not. So it is important to highlight that the IPSS scenario would need to be moderated, so it had to be above 8. Otherwise, the symptoms would be too low. Also, we can see here the exclusion criteria. So we eliminated all the patients with cancer conditions, and we've eliminated also those with a pacemaker and any heart disease. So yeah, I need to speed up a little bit. So now we have our conclusions here. So we've been working with about 15 patients with different comorbidities, and the most relevant ones were metabolic comorbidity. We have patients with diabetes or obesity, and according to the studies, I'm so sorry that there is a mistake with the slides, but the presence of these comorbidities, with these metabolic situations, this can reduce the efficiency of the treatment. So in the questionnaire, we discovered they improved a lot, but what were the symptoms? Well, we need to consider that prostate apoplexia, there's various symptoms, and the irritation was the most common one, and according to the protocol we had to follow some instructions with the echography and the dosage of SAE. So through PSA we didn't see many important differences in the times between 0 and 1, but we can highlight the increase of the volume of the prostate according to our protocol. And this was not linked to worsening of the patient. And all the patients improved. So the hypothesis, the pathogenetic hypothesis, would highlight the inflammation would be one of the hypotheses. So diamagnetic therapy is linked to an anti-inflammatory effect. And this brings an advantage because the inhibitors, the alpha-lytic inhibitors and 5-alpha reductase inhibitors, these can be an alternative to those drugs. So now these are really my conclusions. So the key point is that diamagnetic therapy has reduced the symptoms of prostatic hyperplasia, and it would be useful to analyze the effect of this therapy in the case of refractory patients, especially because the patients run the risk of being subject to surgical operation. So I'm just conclude saying that we need to conduct more studies to have many more patients participating. So with all the different options, different machine devices, different protocols, but we need a standard protocol thing for the future of research. Thank you so much. Thank you so much, Gianmarco, for your paper. So next, we're going to have another clinical cases speaker. This is Fernando Gallego. Thank you. Good afternoon. I want to thank Carlos Abad, Sanax, and Fisaude and Parisa for inviting me to participate in this great conference. So I'll be telling you about the activities that we have in Ibermutua Vigo with our CTU MIGA-20 pump. So I want to thank my colleagues in Ibermutua Vigo. This is our physiotherapist working every day with our Diamagnetic pump. So they helped me prepare this paper. So I'm not going to talk about a specific case, but I'll go through a summary of the activity that we've been conducting for the last 2.5 years. And I will show some clinical cases and then I will jump into the conclusions. So first of all, I'll explain what we do. We are work accident insurance. So we collaborate with the social public health service to deliver services to the employees or freelance. So our patients, they're all coming from a work accident or cases where there is an accident. It doesn't happen at work, but they develop some sort of a disease and they have a temporary situation where they cannot work and they may be waiting for a medical consultation or waiting on some tests. So with the Diamagnetic pump, we first did a small study to see the results that we would obtain to decide whether to buy or not the pump. And the results we had were very good, especially if we take into account 3 factors first, of which are the psychosocial and working conditions of the employees. Second is the best therapy is where you get paid. And here in our insurance service, we do not get paid. It's all covered by the insurance. And then second, we're in Galicia where people are not very direct. So when you ask how are you doing, they always say more or less okay. So they're never very direct when answering yes or no. So it's been more than 2 years working with the Diamagnetic pump when we work on all musculoskeletal pathologies. So I'll jump into some clinical cases which shows which type of patients we have to see the results. So first of all, we had a male, 31 years old, with a fracture here in the 5th metatarsian bone. This happened in 2022. He had a pseudoarthrosis, and there was a decision to have a surgical intervention. This was from December. And actually the needle broke during the surgery intervention. I think we're missing a page or something. I think we're missing a slide. Oh, that's a pity. Yeah, we're missing one slide. We may get to see later. So, the surgical intervention was on the 1st of December, and then we started the physiotherapy on the 27th of December with Diamagnetic pump, and we just did this with bone tissue stimulation with 20 sessions. First it was every day, and then every second day, and the results were amazing. We don't have the results, the image, but there is a very good callus bone. We cannot see now, and then the patient went back to work. And this was the case. We had a patient, 41 years old. In July, she had a multi-fragment here. She had some external fixation devices, and then an osteosynthesis. At the same time, she had this pain at the four side of the leg. This was not closing and not closing. Then she came to us in November, where we started the physiotherapy, and the patient was very depressed. She didn't want to see her leg, and a lot of pain. So first, we focused on stimulating the cell membrane to improve the area. And then we were stimulating here the cell membranes. After 1 week, you see here how the tissue is curing. What you see here in red is because of an allergy from the coverage that she had, nothing to do with the pump. And here you can see how this is closed, the wound is closed, and you can see that the quality of the tissue is much better. And she had been with this situation since August with this wound. So after August, we concentrated on stimulating the bone tissue and eliminating, of course, all this situation here. And also here you can see the elasticity of the tissues is quite good. And this was in April 2023. In this case, it was a 50-year-old patient with an impact on the knee in February. And in radiology, we can see it was a bone edema in the internal part and also in the soft parts, also with a very strong synovitis, with a very strong functional situation. He was treated 2 months with Diamagnetic therapy, and the same radiologist reported that the edema was resolved completely. You can see here the difference in the images. And the most important thing is the patient no longer had synovitis, no pain, and recovered completely the mobility and went back to work. This is a patient who had an operation from a breach of the Achilles tendon. And she had some treatment, physiotherapy treatment, and after a while our colleagues sent her to us because even though she was evolving correctly, she had a pain here and she was missing some elasticity in the tissue. So we had 2 weeks of treatment, and the patient said that the pain was going down and that she could do the exercises without feeling the stiffness. So she went to work. We continued treating the patient. And here, well, this picture was from February. She was already jogging. And the last case is here. This is a patient, 46-year-old, with a bilateral damage with an anterolysis and a lot of pain, and she cannot turn around and cannot even go to the toilet without pain. She could not sit on the toilet. She could not sit on the toilet, and the pain would not improve. And even when she was in hospital, she would be doing some physiotherapy in the hospital, but no good results. So we received her the 12th of August. She came with some support to walk, and she needed aid for everything and to move out of the bed. And she had no abdominal muscular tension. So we did a daily treatment for 2 weeks with those parameters you can see here, and the patient experienced a very good improvement regarding the pain, which is the first thing you want to improve. So when you improve the pain, then you can move more and do more exercise, and this was her case. So we continue with the treatment twice a week and then once a week, and she even stopped taking the painkillers. And in total it was 24 sessions, and then she continued with a conventional physiotherapy to improve her movement, and now she has a totally normal life. So with this, we just wanted to show the different cases that we have, and these are our conclusions that we have after these 2.5 years. So first of all, here we obtain very good results, and with a very good improvement of the skin, of the tissue, and a reduction of the pain. So very quickly we obtain a good control of neuropathic pain and irradiated pain, and with this we improve the possibilities for mobility for the patients to do other things. And rather the tendons, when it's a surgery intervention with a pump, we manage not to have difficulties with the scarves. So with this, we can see how well our results are not very different compared to other techniques, but here also we can treat different patients who work in slaughterhouses, in the meat industry, maybe doing the very same movement for many years, or frozen fish, or in the shipbuilding. So it's patients who may not be improving a lot or very quick. So at a muscular level, it is astonishing how we can have an improvement of the acceleration to reduce hematoma and edema. And in the patients we had no complications with the scars that can build later, and then there is pain there. So the results we had were very good. And where we use it most is at an osteoarticular level, because this helps us a lot to consolidate fractures, and also for the bone density. And this allows us to reduce synovitis very well. And it also helps for the ligaments to reduce pain and to improve elasticity. So with this, we accelerate a lot of the processes and recovery is much quicker. So yeah, I apologize that it took a couple of more minutes. Thank you. Thank you so much, Fernando. That was amazing, this paper and the images you showed. So we're going to have the last clinical case now. And this is Santiago Poset. Thank you. Good afternoon. I'm very privileged to be here with all these big professionals who are here to showcase the use of diamagnetic therapy. And I want to thank Jose for inviting me here to contribute to this conference. Also, I want to thank Iria because she's so passionate, and by explaining this in 10 minutes in the Physio Expo in Madrid, she communicated the effects of this diamagnetic therapy to me. So she very quickly convinced me. It was love at first sight. So we had the machine 3 weeks after the physiotherapy fair. So we were working with the protocols from Pariso, and also we were training by Iria. And of course, we had some intuition to adapt, to use, to understand how the machine works with the pump. So Jose asked me to show some clinical cases. And this is where we can see the best results. So I actually had a patient who had an intervention recently with a rhinoplasty. She came for another reason. She had some cephalia, and she told me that if she had known this, that she would have such strong headaches, she wouldn't have undergone this operation. So as when I discovered this, I asked the doctor who was searching, and I asked the doctor what the technique was about and what he had done, and they told him the effects of the diamagnetic therapy, so that the patient could go through this phase as good as possible with no pressure and with the symptoms that she was suffering. So the doctor trusted me, luckily. Now we've become friends. And for 2 months, we're treating patients. We've started a protocol where we treat the patient 24 hours or 48 hours after the operation. So very briefly, I'll tell you about rhinoplasty and this open technique. Also, we'll talk about the different about the different symptoms for the patients who come to us, and also a treatment protocol that we use. And we'll see the results and some comments. So this is the sequence that they do. I wish I will have more information, but this is just to summarize. This is damage that happens to the tissues after the surgical intervention. So there's a dissection suprapericondric over the alar cartilages and superior laterals. So these are the different steps of the operation, and these are remodeling with an engine, and yeah, and then in the end you can have some infiltration of fibrin enriched plasma. So here you can see how after some months, well, this can be the result, the final results. This is 1 year at the end, and this is a patient here. In this case, it was after 1 month, but after 1 year, you can get to see these results. Some are aesthetic, are on aesthetic purposes, but some others are because of breathing problems. This was one of the first patients that we had. This was 1 month after, but 24 hours after the operation, the patient came like this to our clinic. So with these 20 patients, we were asking about their symptoms, and mainly what we see and what they all describe. Well, mainly it's been women, and they all describe the feeling, this big inflammation that we can see here at an orbital level, a big feeling of congestion, and they cannot release this because they cannot do anything on the nose. And some feel a lack of sensitivity on the maxillar and a general pain. And many feel there is this big pressure at the frontal part, retroocular area. So we propose a protocol for treatment with the goal of accelerating all these processes so that we can also avoid infections. Sometimes he uses self insertion of areas from the ribs with the cartilage, with a graft from their own body. And we asked the doctors, and they use the low baric chamber for after treatment. So even though the effect in the long run would be good, they cannot stand the session of the hyperbaric chamber. So I explained that our therapy is non-invasive. So it's very much better with our treatment than as compared to the hyperbaric chamber. So we intervene 24 to 48 hours after the surgery, and of course it depends on the patient. So they're sent home after 24 hours. So some of them go home for a rest, but some of those come to our clinic. And then if it's been 24 hours or 48 hours, depending on that, when it comes to moving liquid circulation, then we stimulate at the highest power for extracellular and intracellular with the low, so that we do not modify the internal mechanisms for regeneration in the intracellular membrane. And also here, depending on the clinic of the patient, here we use the stimuli of the cell membrane 10 to 15 minutes. And whether there is pain or not, we intervene here with a pain control program where it can be high. So we do not work with diathermy and no electrodes, but we just as close as possible to the face of the patient, and then we move for the movement of liquids in the orbital area towards the different ganglia. And then for the cell stimulation, we focus a lot on the nose area. And so then we have the pain control. And in the second session, and after the first session, all the patients said they felt they're relieved of this congestion. So after 3 or 4 days, I think explained before, the treatments are done every 3 or 4 days. So they come much more with a big release, and they're very thankful about this relief and release of pressure. This will be like the protocol. This is where we start stimulating the cartilage. And after that, some patients continue up to the 5th session. So it was recommended to do up to 5 sessions. And in some cases, we see that there is some neural affection. Sometimes they're missing some sensitivity here in the orbital of the lips. And so we stimulate the slow fibers or the quick fibers, depending on the clinic. So here we see the results. So this is the same patient. Here we see 10 days of difference. So the patient explained she felt much better every time she came to the session. This is another patient who had also had an orthoplasty. She had lots of pain and some cartilage had been taken for the 7th rib. Also, we worked on that area for the movement of liquids. It was a protocol for just 10-15 minutes to reduce pain. It was also quite good. And this was the first patient that we saw. It was 5 sessions within 14 days. And we see the bandage at the beginning. And then as the days go by, the inflammation goes down. Here we have more images. So in this case, in the first days, she could not breathe properly, and this was quite damaging. And then she felt the biggest improvement after treatment of the machine. So far in 2 months, we've treated 19 women. Only in one of them, in one of the cases, there was an infection. But because of bad praxis, the patient touched her face and then she got an infection. But in all of them, there was a big improvement. So there is a big reduction of a hematoma, as the doctor said to us. And there is a smaller inflammation. So that would be all, and I hope this can be useful, all these ideas. Thank you so much. Thank you so much, Santiago, for your paper. So before we move on, we'd like to apologize Gianmarco, because there was some problem with his paper, and not all the slides were present. We'll try to adjust this in the post-production so that we can see them all in the video. So now we're coming to an end of our first day. We saw the first blogs. We've already seen a 3rd blog with the practical cases. So I really hope that these practical cases helped you to better understand the diamagnetic therapy. So how can we continue now? Well, what if we now treat some patients for real cases? A big round of applause for the therapists now who are going to now treat our 2 stars. So now we're going to try to work with 3 therapists with a great experience. We're going to work on 2 patients with CTU Mega 20 and CTU waves, and we'll see if we have the time. and we can do more cases. But so in this case, the therapist will help us will be Iria. You already know her very well here in Spain. She has a lot of experience in the use of our CTU Mega20. Estefania Torres, she's also a physiotherapist and has experience in both machines. And she knows this new technology very well. And also we'll have a sports expert from Colombia, Dr. Karen. And she works in her intensive care unit with clinical cases of high cost, so that we can have also an open dialogue and debate on how we do the therapy, why, and so that you can observe the different cases we're going to be working on. So I hope you will enjoy the sessions. And now will be the best moments for interaction with our therapists. So we'll arrange this quickly, and then also the machines will be outside afterwards if you're going to do any therapies or if you want to ask us to continue understanding the use of the devices. Thank you.
Bien, les pedimos un poco de paciencia mientras se prepara la terapeuta.
Please be patient. The therapist is getting prepared. We're calling the real patients with the real pathologies, and they're going to be treated here, and they will give their impressions about the treatment. A round of applause. Hi. Okay, we are here again. So 2 of my patients are going to come, their mother and daughter, because it's been like that. And we're going to talk a little bit about the treatment protocol. I've been doing 2 sessions with the mother and 1 session with the daughter. Dr. Karen and the Dr. Stefania are going to be with me so that we can see the clinical reasoning of the treatment and that we can have a good time seeing how technology works. So she's Esmeralda, she's my patient. How many sessions? Okay, 3. We've been doing 3 sessions. Should I give information? So it was 15 years ago. 20 years ago, you had a sarcoma, and you had a prosthesis, and then you had a relapse of her when she was pregnant of her beautiful daughter, and they waited until birth before she went into surgery. It was her decision, and you had a total prosthesis. No, it was only in the soft part. So they kept that prosthesis. Now, on the 4th of May,
el día 4 de mayo, sí. Nada, el día 4 de mayo me hicieron un recambio de la prótesis porque, bueno, se había deteriorado el trozo de húmero que me quedaba mío, se había deteriorado por completo. Ya estaba deteriorado cuando, en 2008, cuando la recidiva. Y bueno, ya han tenido que quitar el trozo de húmero que me quedaba, han dejado un poquito, que es lo que inserta el codo, para que pueda tener la movilidad del codo, y me han puesto un aloinjerto, un injerto de hueso, y sobre el injerto de hueso otra prótesis. Esta ya, la otra era una prótesis muy distinta, pero esta es una prótesis estándar de húmero, porque ya han podido poner una estándar, que la otra vez no pudieron. Y eso es.
Y viene derivada de otro paciente que traté en Madrid porque ella contaba que tenía problemas de cicatrización, tenía un queloide de la antigua operación, entonces como le hablaron de lo que hacía de los milagros diamagnéticos, entonces se puso en contacto conmigo para saber si justo después de la cirugía la podía tratar con la CTU, y así fue, empezamos a tratarla con las grapas y con el vendaje, y
Sí, fue a la semana y media de la intervención.
y la tratamos después a sacar las grapas, y la enfermera que te dijo que...
Nada, me dijo, madre mía, qué bien cicatrizas. Digo, pues no, no es el caso, porque cicatrizo fatal, cicatrizo muy mal, pero es verdad que esta vez, bueno, la cicatriz está perfecta para como yo cicatrizo, claro.
Se ve perfectamente el trozo del lo podían haber hecho un apaño, pero dejaron la cicatriz anterior, la cicatriz anterior con las grapas está mucho más fea, y la cicatriz nueva tratada con la mea está, pero vemos algo.
Chicas. Girls, come in.
¿Dónde estás? A ver, está aquí. Con ustedes.
So, Dr. Karen and Dr. Stefania. Fernando, what about you?
No lo veo. Ah, este es de pedal.
Este aquí se mueve.
Yo, especialista en diamagnetoterapia, solo. Camillas, no.
You know, I hate stretchers.
Iria, ¿vas a poner este disco?
¿Qué?
¿Cuál disco le vas a poner? ¿Este?
Sí, cualquiera.
¿Sí?
We are going to use any discs because we are not going to treat her with diathermy. We are not using diathermy unless there's a continuity in the tissue. So please lay down. We brought some towels. Could you ask, please? Because we brought many towels for these. Okay, are you feeling comfortable?
¿Se puede proyectar a la pantalla?
No sé si...
Can you see? Okay. Can you see her on the screen? I don't know if you can get her. Of course, you can come to the party after that. So this would be the fourth session. So we are in the fourth session. Lolo, could you please show the picture that I sent you? Please thank Lolo because he's been the guy who's managing all the slides. So can you see that picture? Lolo, can you put the other scar? So you can see that in the top, you can see that this part has nothing to do with that part. So that's the old one and that's the new one. And the staples were there. So that's not inflamed at all. I thought it was going to be a little bit inflamed so that you could see the pre-treatment and the post-treatment. But well, are you feeling any pain? No? Yeah, you are feeling more pain in the elbow. Yeah, you have a little bit of inflammation, but just a little bit. Yeah, the inflammation is deeper, but before we could see the tissue in those areas, but it's not visible anymore. That part is very soft. She had more pain in the elbow, but because that's where she had these separators in order to work a little bit more. She was complaining more about it, about the elbow pain. So we started the first session. The first 3 sessions, we did fluid displacement, intra-GI and intra-GI. And after that, we did the cell membrane, and we wanted to have a very good graft. So that's why we used the cell membrane and 5 minutes of cartilage bone for the part of the graft that she was put in the bottom. But the higher volume in the first session, it was about fluid displacement because the edema was very big. And cartilage bone so that the graft can work. We also treated the cervical in the second or third session because, you know, she had a lot of pain for a very long time, so the cervicals were damaged. So we wanted to tackle the central sensitization because she had a pain for a very long time in the shoulders. So we should not forget that those are the symptoms, and we need to treat the possible consequences that might happen because of that central sensitization of cervicals. So can we start with it, like with the fluid displacement? Okay, thanks to artificial intelligence, we need to write some requirements which is regarding to symptoms. So we can ask the patients about their static pain. So I can ask you, do you have any pain right now? I will ask you that. Okay, you don't have any pain right now. Very good work, Miriam. Okay, can you please pressure this card and we can check if she's feeling any pain? From 0 to 5, how much does it hurt? Okay, 1 out of 5. Any difficulties to do some movements? That's another question we usually ask. For the moment, I cannot move it. She cannot open. So 5 out of 5. So she has some difficulties in the hands. No, she doesn't have any. So there are not generic dysfunctions, additional ones, something that happened before with the scar. So now let's start with the fluid displacement. So we can choose if it's extra low or intra low, and in this case we are using extra high, intra low, extra high. You want to continue with the same one, right? Would you change that at some stage? No, it doesn't make much sense. I would continue with it because I'm treating the cervical as well.
El feedback con la célula entiendo que tiene que seguir trabajando de la misma manera.
Feedback,
Sobre
I
todo en la
guess
parte de
we
abajo.
should be working with the same way, especially with the part in the bottom. Yeah, when we use extra high and intra high, that usually works on the cytoskeletal at the cell level, and coding extra, that's the movement that happens from the internal part to the external part. That's very complete, actually.
El aplicador.
Okay, so that's the applicator.
Vas tú, te va a parar el equipo, papá. Si tenemos esta que separamos. Se necesitan 3 mujeres para.
We need 3 women.
Ahora aquí, listo. Bueno, ¿me lo va a pasar? Bueno, yo os voy diciendo un poquito cómo hago en la clínica.
So I'm going to explain a little bit what I'm doing in the clinic.
Podemos modificar el RAIS, vamos a dejarlo como está, porque es las... Bueno, iría el RAIS, perdón.
What's the RAIS
el
for?
RAIS, esta tecnología, corrígeme si me equivoco, trabaja por trenes de 4 milisegundos. El RAIS es cuánta cantidad de energía mete en esos 4 milisegundos. Tanto por ciento de energía, o sea, para ponerlo más fácil.
So,
si hay un 100% de
for
energía
example,
que tiene
if
un
we
RAIS
have
del
100% of energy, and if we have a rise of 50%,
va a tardar el 50% del tiempo
in
en
those
llegar
4
al 100%.
milliseconds, it will take 50% of the time to reach 100%. If we put it
no va a tardar nada en
100%,
llegar al
it won't
100%.
take anything to reach 100%. Is it clear?
Es la misma.
Any questions?
Es la misma duración del ancho de pulso que tiene una onda. Entonces ustedes tienen una onda que
But for example, if you have a wave that can be measured by third parts, and we check in milliseconds what's the pulse range of that wave. So the closer that wave is, the quicker the energy is.
Es muy importante recordar que estamos haciendo terapia diamagnética, que es una terapia que metemos dentro de nuestro razonamiento clínico y dentro de nuestra forma de tratamiento. Entonces, esto a mí me permite, como he hecho en la segunda sesión, por ejemplo, dejé así el manípulo y le hice punción seca a los trapecios, porque tenía mucho dolor referido y estamos haciendo sesiones de 30 minutos. Con sesiones de 30 minutos puedo hacer muchas cosas y tengo las manos también para tratar. Entonces, dejaba la máquina puesta, le estaba pasando los trapecios con punción seca y luego drenaba. Y más o menos como venía con inflamación, sabiendo hasta de dónde llega la prótesis, dónde había más inflamación, dónde está el injerto, es muy sencillo porque sabemos que el manípulo trabaja en esta superficie con 3 centímetros más de diámetro, bueno, a cada lado de la superficie, entonces casi estamos tratando entonces dejamos entre 3 y 5 minutos, luego movemos el manípulo para aquí, el manípulo para aquí, el manípulo para aquí, y estamos tratando 12 minutos toda la zona con desplazamiento de líquidos. Después hacemos lo mismo como membrana celular. Vamos viendo cómo cambia el tejido y al final nos quedamos un ratito más y podemos hacer pases ya donde con los dedos veamos que es más necesario estar más tiempo.
Whatever we think it's necessary and longer.
Acá que estoy viendo el panel, me gustaría colocarle skin y muscle.
I would like to skin muscle. That's where we want to intervene. That's for the fibrosis. So we're going to give a mic to the people on the chair, so in case you have any questions, because this is very dynamic. Or if you want me to focus on something, or if you want to ask any questions, I mean, it's a very good opportunity. You have the mic on the chair. So, hi. When it comes to prevention and the movement of the muscle, for how long? What's the quality muscle internally and externally? And I think it's a very good idea to keep stimulating the muscle as well. Yeah, of course. As long as we keep doing the treatment by different protocols in this first session of treatment, she was told that she had to be 2 months without moving her arm with the sling. So the main objective here is that, as we know that she has a very bad healing process, that her elbow hurts and she cannot sleep because of it at night. So the objective, my objective when I saw her was that first we are going to start working with the inflammation, with the fluid mobilization. We are going to work on her healing process. Then we will make sure that she has no pain, and in the future sessions we are going to treat the skeletal muscles, all the involved muscles, and the fluid mobilization in the cervicals, in the central sensitization, and we want to treat the nerve tissue in all the peripheral part, and that's how we distribute the objectives according to which session we are and according to her feedback, because I cannot imagine the protocol. I mean, I know that she's going to come, but I can change the protocol as long as I see her and as long as she tells me how she's doing. And yeah, that's important. I mean, the treatment is not static. It can change. Every time I touch her, every time I ask her, I will find a very different patient, especially with the diamagnetic therapy. In those cases, it's very important to dynamize the protocol in order to have different objectives in all different sessions and to reduce the rehabilitation processes. Yeah, sometimes you are treating a specific type of pain and then you realize, like for example, if you're treating a very specific type of pain, you realize that the patient keeps having that continuous pain and they cannot mix. For example, there is a neuropathic pain. It led to another type of pain. So you can use both protocols, the neuropathic one, for example, and you can do some frequency sweeps. And there is no need to have direct contact with patients. And that's a very good tool for us because you can start doing like the sweeps on this segment to work in a very complete way. So for example, if patients are very severe after surgery, like without contact, you can work up to 1 centimeter or 3 centimeters of the skin, and the effect of liquid repulsion is gonna be the same. So the magnetic field is doing great in this regard. So for example, in the first session, the scar was covered. I did not uncover the scar. I was doing the same, you know, but the scar was covered with the staples, with the bandage, and I was working more in the shoulder joint where we could see a higher inflammation. And then the other one was with the staples, and then the other session was without the staples, which is this one. I have one question. You've done the technique from proximal to distal, but is it like that for any reasons, or you can do it the other way to guide with the lymphatic system? I could have done it whatever. The machine is very powerful. At first, we were like, we are going to follow the channels of the lymphatic systems, you know, tonsils, but you can do it the other way. The machine is very powerful. Like, you can see, like, when you're using the cuff, it repels the liquids. Like, for example, if this scar was in a tonsils area, for example, if this scar if the scar is very hard and it's in a tonsils area, we need to start treating where there is more liquid. Or for example, where the tissue has more edemas. So I would start there. I would start with the machine for 5 minutes and let's see what happens. If I don't see any changes in 4 or 5 minutes, maybe I'm doing something badly, or maybe I need to incorporate diathermy. I really like that question. For example, in an acute trauma, can you see the mark, right? In cases in which we have a severe trauma, the cuff has to be located in the lymphatic main source. You prepare that for 3 or 5 minutes, and yeah, in that case you would go to the area with the most edemas in order to conduct the frequency sweeps in order to have quicker results. And what's the goal of this? We want to handle pain. We want to reduce the drugs consumption. For example, in a traumatologic room, you know, you have to be there every 6 hours, every 8 hours. We want to reduce that. And in order to prepare the soft tissue for a next surgery intervention. So yeah, we should consider that, but in cases of severe trauma and in specific cases with lymphatic systems that you know about, and thanks to lymphanographies, you know what's the area of adhesion. Like, I wouldn't use the cuff. I would just use it what the injury is, because I would remain there. But that's when you have a very chronic pathology and when you have like a map or something that's very specific so that we can intervene. Additionally, I really like working with patients' positioning. For example, if patients have a very big edema in their knees, we put the leg up and we use the diamagnetic pump so that the fluids can move and they are back by following the lymphatic channel. And we can tell the patient to move their legs, to move their knees, And that's helpful because the muscle pump is activated, so that's more effective. There is a very asked question regarding discs. For example, some students or some colleagues would ask me, why first the black, then the gray? And I thought it would be a great idea to share that. So the additional equipment to doing a very strong diamagnetic pump has a radio frequency element, so you can work with heat elements to conduct dilatation so that fluids can move very, very quickly. So when we do these type of interventions where the patient is not very severe, we do some thermotherapy with some extra fluids in order to have a good evacuation. So there are some special discs for the part of soft tissues and some disc for bone tissue. So the equipment allows you to have one part from bone consolidation management and another one for management of soft tissue. So you can choose the small one for the smallest area so that the electromagnetic field can work in that area. We can use medium, middle, and large. And you can choose it according to the area you want to work in. So those discs in radio frequency have to be treated with cream because the wave will hit the tissues a lot. I have another question. The small applier is resistive. Yeah, it's resistive. So this small applier focalizes the diamagnetic stream, the diamagnetic jet, and it's reaching vitamin Z, and in very small areas you can place them. Those areas that are very difficult to access, and you want to have contact with patients. But we know that the cuff will have the possibility to go up to 7 centimeters of deep without touching patients. Okay, one thing, now there is an electrode that's like having a beauty aspect, but I could work like this. Right now we're not using diathermy anymore. That's because of hygiene. That's PVC, so I can put it there, and that's the one that I'm washing, and I wash it for the next patient. But I could be treating her without the electrodes or at a distance, and I have to select that component when I select diathermy. So one question, the ulcers of one person that has some bandages are better with contact or without contact? Without contact. It's very important to be careful with the infection of the open injury, like in contact with a bandage or without contact with the bandage, as you wish. In my opinion, we are physiotherapists, and our main tool is being able to touch, to arrive to patients, to touch patients, and patients are very used to it. I really like touching. It looks like if you're not touching the patient, it's like you're not doing anything. And that's important to have contact with patients, but you can have that biosecurity distance. You can leave your arm, like pending. You can establish some distance so patients can feel confident and safe, and you can feel safe as well, and you can stimulate in the top. You can stimulate some pain fibers that might generate a positive response towards patients. So we also have this small device, and we would put it underneath the disc, and there is a noise every time the electromagnetic charges, so that patients feel that they are doing anything, because there are not signals, patients cannot feel anything, so patients like the noise. So we use it quite a lot, so that patients can feel that they are getting a treatment. And also for children, for example, if children are like, there is something very hard in children, they would be scared. So I think that's important to use. So that's why we're using that part. So there are patients that like the noise. You can charge them a little bit more so that you can get rid of it. That's important, because that can give you a headache. In the case of patients that might be infected, or maybe just think that they are infected, or maybe you can get that infection or provoke an infection between patient and patient, we would do a disinfection with ultraviolet lights in the case of the trauma room or in surgery. Tomorrow, you will see a little bit of those cases in areas with which we require a higher asepsia. Like, I need to have full aplepsia if I work with different patients, so the ultraviolet lights are a very important source for it. They are very easy to use, they are great, like they work in 15 seconds, and they are very cheap. When I create ulcers, I like to see the ulcers, I like to clean them. We create this surrounding area, and when I'm putting the pot on the ulcer, I cover it. So that's how we can create this surrounding area so that there is no contamination. And you can see how the tissue response is, because you can see that in the moment. So most of the times we are going to change the reasoning. What we are going to put, if we see that there is some blood arriving to the ulcer, we can see if there is some water. So yeah, we think it's a very good idea to see the ulcers. Now we are doing cell membrane for an update. We are placing the extra matrix cell. I wanted to ask you a question. What's the patient feeling right now? What are her feelings? I can't feel anything. Can you hear me?
¿Oís a la paciente? No noto nada, la verdad. Noto un poquito de calor por donde me pasa, pero nada. Ni siquiera noto el peso, que a veces cuando lo dejas un poquito se nota un poco más el peso, pero bueno, porque yo tengo el brazo que enseguida me duele un poco, pero ahora mismo que lo tienes sujeto no noto nada, es muy cómodo.
¿Y venías con dolor?
Bueno, siempre me molesta algo, pero es que todavía tengo el brazo como muy acorchado todavía. Entonces no tengo dolor como tal, no tengo. En el codo un poquito más, pero bueno, no es que bueno, estoy tan acostumbrada al dolor que ya no sé decirlo. No me duele mucho.
En el codo las primeras sesiones sí.
Sessions you had a lot of pain in the elbow, right? The pain of the elbow was eliminated in the 4th session. Whenever I use the pump, I can do an assessment of the patient, which is a very specific one, because changes every session are very important. So you can assess sensitivity, pain, scars, and even the tissue temperature. And it's very important that you check all these things, because changes usually happen very quickly with this pump. I have one question for you. I can see that in post-surgery they are not using diathermy. They are using it more in chronic patients. So has that been your experience? Well, I always work according to my objectives, according to what I see and according to what I want to do. So for example, if she had a hematoma and a structure one after surgery, that happened. I mean, I saw that. And there are some surgeries, because of paroscopy, that hematoma is very close to that joint, and that's why we cannot move properly. So if I want to get rid of hematoma that's structure, I would use diathermy, whatever that happens. I would not use diathermy in an open injury, but if there is a structure hematoma, I would use diathermy to drain that hematoma. If I only want to drain, and when we start draining, I see that at the 5-8 minutes, the tissue changes, I won't use diathermy anymore. I mean, I have not found the cause. Like, for example, let's talk about the thickness of the skin. I have to use diathermy because I found that there are many prominent thickness. And I've used diathermies, and I found very fine skins with edemas, and I had to use diathermy. So diathermy is like the turbo boost of the machine. When that draining is not happening, I would use diathermy. In this case, so as you can see, that keloid was cut and that was unified with the staples, but if I wanted to treat a scar that was very thick, I would use the diathermy, but I would finish without diathermy with fluid mobilization. But in order to flexibilize that scar, I would do it with resistive. And I would add that with the head, you would use the head to treat the thickness of the scar. Yeah. Like, for example, if there is an athlete that has gotten an injury, would you use something hot in that injury? No, you wouldn't do that because you would produce worse blood. So we want to close the blood vessel, so that's the same. So we need to be very careful of not using diathermy 72 hours after the trauma, and then we need to get to know the objectives of why you're using diathermy. You need to train, they need to train, so you can have a very low frequency so that there is not an excess of heat that will cause an inflammation, a higher inflammation, of course. We need to consider that it's not like a normal diathermy. This diathermy is like the push and pull effect. It's like draining all the time. So whenever there is heat, it drains, it drains, it drains. And that heat and feeling, the patient won't have it as with normal diathermy. So for example, with other diathermies, patients would be screaming because it would be very hot. But now the patient is very comfortable because there is oxygen, there is CO2, there is blood, so with temperatures of 3, 4, 5 degrees, we can drain perfectly, and there is no need to think that the patients will have a bad experience or that they will have any problems. So, okay, I have one question. So you were talking about treatment with children. Should we be careful regarding growth cartilage? No? Can we treat it in that area? For example, now we have the CD1 For example, Dr. Felipe has been working quite a lot with children on the head, and he had very good results. So that's why we got this specialized team in order to work with children. Of course, you need to be careful with the way you use the equipment, because the equipment has a very high intensity magnetic field, but when you place the type of tissues that you're going to place, the equipment is adapted to the frequency of tissues and it stimulates. It's not about you placing the equipment and there is bone, ligaments, cell membranes. No, it's not about it. The idea is that the equipment can adapt to the frequency, so that's why we put it step by step. So for example, if you're going to work with children, you should avoid bones so that you can work a little bit calmer with that effect. It's important to say that reaches 7 centimeters depth and 3 centimeters in the outside part. So if there is anything you want to prevent, it's very important to consider the characteristics regarding surface and depth. So if we prevent that surface and that depth, there is nothing bad happening outside from those same characteristics. Hi. So regarding rays, in what situations are we going to use it? Are we going to increase it? So those are the recipes that you want, but I'm very sorry. There are some recipes. So those are objectives. For example, you're in high-performance sports or in the tennis open and you need to trade that person very quickly. You need the energy per time and in immediate time. So that's why I would increase the rays. I have like a polytraumatism that would happen in the mutual association and the patient comes in. And what should I treat him? Like he was hit by a lorry. So we have 20 minutes. So you should treat everything and you would increase the rays. But it's the same. We cannot have the rays at a high level because the machine cannot be working 100% all the time. And like, for example, we need to know that the engineers should know that if we use these rays, it's how we usually need to treat the patients. When are we not using the rays at a normal level? When there are some specific cases in which we have no much time. For example, I had to use it with the drugs inoculation, heavy drugs inoculation, and when I have a very short time to place them in patients, so I have to hurry and I put the rays at a very high intensities, and that's completely absorbed, mopped up. And it has to be in exceptional cases. Okay, I was asking that because I usually work with basketball players and there is a lot of pressure for them to go back to play, and I didn't want to burn the machine, but like I would like to increase the rays. So the concept is not for healing in a quick time, but to see a change in that moment, and that's something that's different. Because at the end of the day, we need to consider the healing crisis. Like if we put more doses, I would increase and accelerate the healing process. So that night, 2 hours might be very painful for the patient. And then it's that. You won't decrease the deadlines because you keep increasing the rays. Physiology is physiology. But what are the differences that I might encounter? So I have an edema, 10 minutes to treat me, so what can I do? Like if you need to go back to the game, so I would increase the rays. But I'm just treating one symptom, not the process. I have to check the process in the long term, and I have to know that the doses are those ones and that those are the times. Yeah, that information is very important for athletes. Okay, so we are done with the 4th session. How are you feeling, lady? Very well, calmer, chilling. So she came without pain. In the 1st session, she had pain in the elbow, but we didn't prepare this. Like I thought she was coming with some pain. So can you see the change of the scar? Yeah, it reduced quite a lot. Not this area, not much. But yeah, you can see that. And if you touch it, you can feel it. You can feel that this scar decreased and the fibrosis decreased as well. Yeah, it's like softer, with less fibrosis. She can mobilize much better, right? And as Dr. Karen was saying, in the next episodes, if she had some stiffness in the arm when she started moving, like fascial stiffness that comes with the scar, we would use the shock wave. I'm in love with her. I'm in love with the shock wave. The economy of the bank is grateful for me being in love with a machine because I'm spending a lot of money. So yeah, if I want to work in a scar that's harder, I would use the smaller lens and I would decide the distance I want to work at. And that's what I can do. I can select the lenses. The defocalized one would be the choice for her. Okay? Okay. Okay, you need to stand up. I'm so sorry. Any other questions for the patient? And now her daughter. Or Candela left. Okay. Okay, thank you very much, Candela. I would understand that you escaped. So she's Candela, she's 15 years old, she's her daughter, she's swimmer. High performance swimmer because she trains 5 days a week.
Viene con dolor en la rodilla,
And she has some pain
izquierda,
in the knees, in the left knees.
Viene con dolor en la rodilla desde hace
Desde
septiembre.
Yo
la traté una vez solo.
I treated her once.
El arreso pone que se intuye que puede haber algo en el asta posterior del menisco.
There might be something in the meniscus.
Mucosidad en la articulación, que
There is some mucosity in the joint.
No sabía si venía con catarro o no venía con catarro, Candela.
I don't know if she had a cold or if she didn't have a cold. But it actually doesn't hurt. It hurts when she trains, so we treated her in the first session. We did some Diamagnetic therapy, shock wave. She had no pain.
Creo que en 2.
She didn't train for 2 days. And you came back to training and it hurt with the same intensity.
Sí, más o menos la misma
Yeah,
intensidad.
more or less the same intensity. I mean, she doesn't rest, and that's a problem. How many days were you not without training? Just 2 days over the weekend. So that weekend she didn't leave the house, right? And what are the movements that make you feel pain in your knees? When I'm doing the hyperextension of the knees, I cannot stretch the knee completely. When you jump, when you go up, when you go down. When I do some strength with the knees, yeah, it hurts. When I go up the stairs, it hurts. It's inflamed, but it hasn't been for a very long time. When you touch her, she has some pain. So, do you feel like a pinch? No, but it's like my knee is like crunching. Something's happening there, but I don't know what's happening. It's like something, there is something inside. Okay, so let's take a look at her. She's our former colleague. So you know the mechanism because you were a swimmer as well. So I did shock waves as well. With the defocalized, and in one point, because she doesn't want me to inject anything. And I did defocalize for the muscle treatment of soft tissues. And then with the lens D2 and lens D4 in the joint area and in the meniscus area. Are we going to use shock waves? As you wish. Okay. I only treated her once. So waves, waves. When was it? Like 1 week ago? Last Friday? I was gonna treat her again. What's the day today? Friday. So I was gonna treat her yesterday. They brought the machines and I said to her that I couldn't treat her. And I said to her, if you want to be treated, you have to come here. It's like in the middle line. Did you get like an MRI scan? Yeah, she did. Maybe she has some mucosity in the knee and in the posterior part of the meniscus. That's the mucosal tissue. It's only when we touch her, right? When I touch her in the posterior meniscus, she would feel pain. I think that's it. When you go to the lateral part, to the side part, which is more muscle, and in the bottom part, I think it's more an inflammation. I mean, of course, we need to consider that she's swimming all the time and she has like a forced hypertension, and she only trains for strength once a week. And I don't think that's feasible. In the ultrasound, we didn't get that. So in the ultrasound, we got everything that was perfect. For me, it was like goose food and course, an internal course. So yeah, that was the treatment, goose food. So let's start with disc 6. Could you please focus better with the camera? Because we cannot see properly. Yeah. Should I focus the knee? Should we increase what? What do you want to see? The knees or the machine? We want to see the knees and the machine. Okay. I started with the defocalized, with the internal course, but with the goose foot I did 4, it did 2 and then 4. I can start with 4, okay. 4 and 6. Idia. Hi Idia, I have one question. Have you considered a posterior iliac rotation? No, we didn't, because we are going to treat iliac in the inside part, but she wanted to train, so we had to treat the pain symptoms. Yeah, but because of the symptoms you're mentioning, it might be a rotation of the goose foot. It might be a posterior rotation, and that's causing a hyperextension at the goose foot level, and that might be the problem. Yeah, and especially because of the movement mechanism that you're explaining. That, yeah, exactly. We would treat that with the mega in the iliac part. But if there is not posterior rotation, I would place the iliac. That's according to the osteopathic vision, but I won't do that with my patients. I would release with my omega, and that goes to that area, and then we do some work for normalizing muscle chains. RF is essential because you can have all that synthetic chain that you want to work with. Yeah, I'm just saying it in order to accelerate this. I have 2 mics, I don't know why. Yeah, we can do it in the future. We can do it at the same time. I can release partially the diaphragm. I use extra high and intra high in the first session, especially because of what you're explaining, because I want to get to know her feelings. If I use diaphragm in the first session, she won't say anything. She will say that's very comfortable because that's producing heat. So in the first session, I would treat with extra high and intra high. Everything that's fascial, because as Antonio Lagata said, it's off. Yeah, we can start with waves if you want. Okay, I'm going to start here. Tomorrow we have all the shockwave sessions. So, what do you want to do? So, as Antonio Gatta said, with the muscle skeletal, we are not going to relax the muscle, but we want that magnetic rotation that the muscle has is in the proper parts, that's working perfectly, that the muscles are working properly. So, for example, if I want to release the fascial, I would do it with fluid movements, intra-high and extra-high. I can see your faces, I don't know if you're agreeing with me or what. So here you have different parameters. Tomorrow we will have the shockwave session. So I'm going to explain a little bit what the team has here. So here we have the energy. That's according to a square millimeter, but we have it in percentages. And all percentages are correspond to the square millimeters, and it can reach 0.5 millijoules. So as it is a focalized shock wave, we can work from soft tissues to the bone parts, hips. We can work with that without no problem. So here we decided to put energy at 30% because we are going to work in the soft tissue, and the rise. That's the pulse width. So if it was 100%, the energy is like the wave that goes down, that goes up and goes down, and every time we reduce the rise, that's gonna be broader. So you can decide if energy should be longer or shorter. So what we can do here, in this case, we can use a little bit more of rise, so that it goes deeply to the tendon part, and you can decide if you can place diamagnetic or not. That's one of the advantages of the equipment. But of course, you know the benefits of using the diamagnetic therapy. So we are going to put 50% for the diamagnetic therapy, and same here, you can put the client's code. It uses AI, so the idea is that you can write that the name of the patient, so that that's uploaded to the system, and you can do several comparison studies with the changes that the patient had. So we are going to put the symptoms. Do you have any pain in your knees right now? No, she doesn't. So 1, when touching, how much pain do you have? 3, and when you make some movements, when she goes up, she goes down, okay, a lot of movement, a lot of pain, 5. Like, she cannot train, so I would say 5. Okay, so everything is modified. So we put 30, 40. If we want to go deeper, or if we don't want to go deeper, we can regulate that with the diamagnetic therapy. So depending on the lens you're using, for example, if I don't want to go deeper, I should decrease the diamagnetism. Or if I'm using a shorter lens, I should increase the diamagnetism. So we can start now. Do you feel any pain now? Anything? Is it agreeable? Okay. We are going to start with the fascia. At the same time, we are managing the kinetics chain. We're going to release, and now we're working on the chain, on the knee. So we could use the plates, so we could say that they are working the whole chain. So we have many different options. So time is over. in neurological pathologies, we use the dual therapy as well, let's call it like that. Like in Guillain-Barré, that's something we've been trading on the brain part, the electromagnetics. And in the soul of the food, we can also use the diamagnetic therapy, and the results are quicker and are very good. So I increase the rise because I'm gonna do a long treatment to release the fascia. I mean, a short treatment. But I want a quick effect, a quick fascial effect in this area. I increase the raise, and it's at 70%. I will explain that tomorrow, but I really like using the discs from the equipment because you can work in a defocalized way. For example, if you need to work in sweeping techniques, it's very useful to work in a defocalized way, and we can complement the static treatment. So treatments with shock waves are shorter. It's 6 minutes, so that you can give the energy that you want. So that's why the treatment is very effective. Yeah, maybe you can record or show what we are doing in the CTU Mega 20. Okay, it's working. Any questions? That's a focal shock wave, and like she's not screaming. That's important. Yeah, it's completely painless. But the shock wave has to be in contact with the tissue if we want to do the mechanotransduction process. That's why we need to use the gel. Is there any pain in the posterior part? Yeah, a little bit. We have to treat that part as well. How much time did you put without turning it on? 15 minutes, and now 15 minutes. We've been working with her for 5 minutes. Yeah, before the machine was not working. It was just to see if you were paying attention, but you were not. So 1 minute left, and now we can move on to disc 6. And that's how we can get the interlinear. There were some towels. So here, I like to show the retinicles, and that's the line where it was. And it's a very mild edema. Okay, disc number 6. That's why we need to clean it. Can I use a towel? You can take one of those papers. Are you feeling better in the area where we were working on? Any changes? No, you're feeling the same? So you're feeling the same? I don't know if you agree with me, but usually athletes train 5 days a week and they train with pain. Feelings are very complicated. It's like it hurts a lot, or it's like I can't feel anything. So their feedback is very complicated. They will just tell you when it hurts, and that's all. So we need to do some sweeping in the area where we have the pain. I don't know. We change the disc in order to change the depth we are going to reach. Now we are working at 6 centimeters. We are going deeper off in the knee. I'm just releasing the diaphragm a little bit. If it hurts, it's my hand, it's not the pump. Yeah, please bear in mind that I won't inject anything. I gotta say that patients that come with low back pain, I would start the treatment in the front part by releasing the diaphragm, the psoas, the fascia, and that's always in the first session. And patients usually ask, why do you start in that part? Because it's in the back. And I tell them, yeah, you can tell me when we are over the session. And it's the first time patients can start feeling some changes, especially if we consider that they've been doing some treatment on that damaged area. Okay, can you breathe out?
So obviously now we need to add in the time we were working before with the machine device off. But it's only been 7 minutes with the machine running. So we've now increased the rise. So now it has less. Yes. We can see now how the tissues are easy to treat. So now, following the idea that we heard from the guy who is no longer in the room, so now for iliac, so with the iliac, we will be relaxing the gluteus minimus. So we'll do some fascia exercises for the muscle, for the pelvis, and now to support the treatment we did. Now we need to move the legs like this. Yes. So now with the gluteus minimus, so now there's lots of tension here. The arm goes up here, breathe in deeply, and when you exhale, please move the knee down to the bed, but without moving the hip here. So keep the pelvis there, iliac here, and the ribs, inferior ribs against the bed. Breathe in deeply, exhale. Very good. And now we're gonna maintain here 1 minute to have some effect on the fascia, the anterior lateral fascia, and specifically on the gluteus minimus. 50 sec. Exhale. So now here, we stretch the arm. So now inhale. Let's count again. Look to the side. This is for gluteus medius. We would execute the full protocol so that she can also do this at home later, before training and before going to bed. So that will be it Thank you. Any questions or comments? Right now I have no pain. And how do you feel? Well, normally, just like this, when I'm standing, it doesn't really hurt. It hurts more when I'm doing some sports activity. So I cannot really tell you so much. Well, now we're not going to put her into the swimming pool right now. Great, so thank you so much. We'll see how she evolves next week. Thank you so much, Candela. Thank you. All right, thank you so much. A big round of applause for our therapists. Great, so thank you so much, dear friends. We are coming to an end of our first day within our second Congress on diamagnetic therapy. So tomorrow we'll start at 9, the doors will be open at 8:30. So now I just say enjoy my trade and see you tomorrow, and thank you so much for your attention. Thank you.